I'm audible and visible to you. Please update me in the comment section. I'm audible and visible to you. Yes. So let's proceed, guys, with the part 2 of obstetrics and gynecology. We already had part 1 and I hope you guys have revised that enough. So today we'll discuss the remaining topics and then revise these 8 hours at a 1.5x speed so that it will be helpful for your upcoming exams. Okay, so let's begin with the first topic of the day, endometriosis. Let's begin with the first topic of the day, endometriosis. Okay, good afternoon everyone. Okay, so meanwhile keep answering, okay, all the questions, keep answering everything whatever you know about these topics, just keep interacting and keep answering. Clear to everyone? Yes. So all the topics that we have discussed in the part 1, abortion, ectopic pregnancy, postpartum hemorrhage, okay, all those main topics, they are all important. So let's begin with the topic number first for the day, endometriosis. Okay, now if we define followed by the topic, we'll solve questions as well. Okay, so let's discuss first in a concise, very concise manner the topic. Now if we talk about endometriosis, what is endometriosis? In a simple words, it means ectopic endometrium. That means endometrium placed outside the uterus. So you can write that it means occurrence of ectopic endometrial tissue. Occurrence of ectopic endometrial tissue. Now that means that this endometrial tissue can be present somewhere else. And if we talk about the most common site, that's going to be, update me in the comment section as well, what will be the most common site of an endometriosis and what will be the age group. So the age group usually will be 25 to 35 years. The age group usually will be 25 to 35 years. Okay, now the theory that is widely accepted related to the endometriosis called as Sampson's theory, and Sampson's theory says that this endometriosis is due to the retrograde menstruation. It's due to the retrograde menstruation. So what does that mean? That simply means backflow of the menses. Okay, and this theory is called as Sampson's theory. This theory is called as Sampson's theory, and Sampson's theory says that it is usually due to the backflow of menses. Okay, now followed by that, if we talk about the investigation of choice, this is your PYQ that has been asked in your exams 2024 recall question. What is the investigation of choice for endometriosis? That is laparoscopy. So the investigation of choice for endometriosis is laparoscopy, and the most common site is ovary. Most common site is ovary, and second most common site is pouch of Douglas. Second most common site is pouch of Douglas. Okay, these are the genital sites. Okay, if a question will come other than the genital sites, okay, other than the genital sites, what is the most common site for endometriosis? Anyone in the comment section? If the question comes that other than the genital sites, what is the most common site for an endometriosis? Your answer goes to, yes, the answer will be sigmoid colon. The answer will be sigmoid colon. Okay, now remember sigmoid colon. The least common will be CNS and spleen. They will be the least common site. So it's all about an endometriosis for now. So it simply means the occurrence of an ectopic endometrial tissue. Okay, the age group usually it's 25 to 35. Investigation of choice will be the laparoscopy, and the most common site for this will be ovary. Okay, the most common site will be ovaries. Okay, now if we talk about the pathological findings or the laparoscopic findings of a patient having an endometriosis, okay, now these will be the keywords that will be present in the question that the examiner can ask. So what are the laparoscopic or the findings of a patient having an endometriosis? First of all, sir, there is a chocolate cyst of ovary. What will be the first one? Sir, chocolate cyst of ovary. chocolate cyst of ovary. Okay, second one will be powdered burn lesions. Second one will be powdered burn lesions. Okay, and one more finding will be there will be a uterosacral ligament nodularity. And also sir, there will be adhesions as well. Okay, और क्या होता है, there will be adhesions and fibrosis. Adhesions and fibrosis. So what are the laparoscopic findings of a patient? What are the laparoscopic findings of a patient having this endometriosis? So number first thing is chocolate cyst of the ovary. The image can be asked, what exactly is this picture? Okay, this is a chocolate cyst of the ovary. Second, they can ask powdered burn lesions. Second, they will ask powdered burn lesions. These are the classical pictures of the powdered burn or gunshot lesions. Powdered burn lesions. Okay, and third one, these are the classical adhesions. These are the adhesions which are seen in a patient of endometriosis. So if a picture will be given, okay, if an image based question will be given from the chapter endometriosis, so remember that if they ask what will be the treatment for the given scenario, what can be the treatment for the given scenario, or what can be the treatment for the given scenario, that's what we are going to learn now. So what will be the presentation of a patient coming to, what will be the presentation of the patient coming to you with complaints of endometriosis? Okay, so first of all, patient will complain of, most commonly patient will complain of pain during the menses, which is called dysmenorrhea. So patient ko kya hoga? Patient will have dysmenorrhea. Along with that, patient will complain of painful intercourse, which means dyspareunia. Which means dyspareunia. Okay, along with that, patient can have infertility due to the adhesions and fibrosis. Infertility. Okay, or patient will also have heavy bleeding during the menses, called as menorrhagia. So what are the classical symptoms? So dysmenorrhea, dyspareunia, infertility, and menorrhagia. Okay, menorrhagia. If the question will be coming from a diagnosis, just you have to diagnose what exactly is endometriosis. They will be asking you a 28-year-old female coming to you with the complaints of dysmenorrhea, dyspareunia, and infertility. Upon the laparoscopic findings, a chocolate cyst of the ovary was seen. What will be your diagnosis? What will be your diagnosis? Simple questions. The diagnosis of the particular condition is endometriosis. Or if a question will be asked in the same scenario, what will be your investigation of choice? Okay, answer will be laparoscopy. Or if a question will be asking now, what will be the management? Now you already see that age group of 25 to 45, that means the treatment will be based more on a medical management rather than a surgical management. Okay, now we'll learn what exactly are the drugs. Now you already know that the proliferation of an endometrium is due to which hormone? That's going to be estrogen. Okay, and in this endometriosis, okay, endometriosis में estrogen levels already क्या हो जाती है, ज़्यादा हो जाती है. Okay, now what will be the treatments? Okay, now what is a protective factor? If a protective factor, you have to tell about the endometriosis, what can be the protective factor? So protective factor can be like progesterone, increased level of progesterone in the body. Okay, so they will do decidualization of an endometrium. Okay, second, smoking is also a protective factor because it will lower the levels of estrogen as well. These are two protective factors for the endometriosis. Now what will be the treatment? So treatment will be something which will be again is the estrogen, anti-estrogen. Okay, treatment will be progesterone orally or IUCD, okay, or injectable, because we need to do the atrophy of this endometrial tissue. Treatment will be GnRH analogs, okay, which will cause a down regulation of the pituitary. Okay, these will be the medical management drugs and the OCPs. Okay, first line management is gonna be OCPs. Now if I talk about surgical treatment, so what can be the surgical treatment for the particular condition? Agar cyst hai, so you will write, so for the cyst we'll go cystectomy. We also go for cyst aspiration, but if less than 5 centimeters. If a cyst is recurrent, we go for cystectomy. Number first thing, sir, if a patient is having this powdered burn lesions, what will be the surgical management? You go for the fulguration of these deposits. okay, fulguration or the cauterization of these deposits, okay. Or if a patient is having adhesions, so we'll just go for adhesiolysis, and this question is the PYQ that has been asked. What is the treatment for recurrent endometrial cyst? What is the treatment for recurrent endometrial cyst? Your answer goes to cystectomy, okay. They will mention a lot of options: cyst aspiration, cyst ablation, cystectomy. Make sure that for a recurrent chocolate cyst in endometriosis, your treatment is cystectomy. Clear? Your treatment is cystectomy. So let's write now what exactly can be the treatment. Medical management drugs. So remember, first line treatment is OCPs. First line treatment is OCPs, and we give these OCPs usually for how many months? 3 months. We usually give it for 3 months. So now if a patient is having this dysmenorrhea to hota hai, and OCP also relieves the pain during the menses, okay. Now if a patient wants to conceive, then you can give NSAIDs. Okay. I'm just mentioning the generalized treatment, okay. So second line treatment will give a progesterone therapy. क्या देंगे बच्चे? So will give progesterone therapy. Now progesterone we can give in orally, okay. Progesterone we can give the IUCD. Which intrauterine contraceptive device contains progesterone? Okay, tell me in the comment section which intrauterine contraceptive device, IUCD, which generation, and what's the name of an IUCD which contains levonorgestrel, LNG. Okay, third generation having a lifespan of 5 years, starting with M. बता दो जल्दी. Yes, Mirena. Okay, progesterone therapy, guys, we can give oral, okay, or we can give IUCD. Okay, which one? Mirena, and Mirena contains levonorgestrel, and Mirena contains levonorgestrel. Okay, we also use injection DMPA, depot medroxyprogesterone acetate, so that it will do the atrophy of the endometrium. So when we give, very good Marina, very good. So when we give this progesterone orally, जब हम orally देते हैं, what it will do? It will do, yes, comment section में क्या लिखोगे? What it will do, guys? Decidualization of endometrial implants. Oral and IUCD, oral and IUCD. Okay, third line agents. What are the drugs in the third line? So third line में we use G-anergic analogs, goserelin, Is that clear? We have other drugs as well, okay, like danazol. Okay, we also use injection DMPA. Now my dear students, danazol is not usually used because of the side effects, because it causes, what will be the side effect? Yes, what will be the side effect? PDF I'm going to share just after the session, part 1, part 2 in the Meduhub channel, or you can join the channel FMGE with Dr. Talib Bilal. Okay, I will share the PDF there as well. Okay, so just be interactive, keep answering whatever you know about these topics. Now, so what is an action of this danazol? So danazol is having anti-estrogenic action. Now anti-estrogenic action, my dear students, you know that estrogen is doing proliferation of endometrium. Okay, now when I'm giving something against the estrogen, okay, what will it do? It will do atrophy of the endometrium. And injection DMPA, okay, yes, side effect is going to be virilization and hirsutism. Virilization में क्या होता है? So there is breast atrophy, clitomegaly, and the hoarseness of voice. And once a patient will have a hoarseness of voice, you are going to stop this drug danazol. They are going to stop this drug danazol. Is that clear? Is that clear? So that is all about medical management. This injection DMPA, you will give 150 mg once every 3 months. Okay, so it will also cause the atrophy of endometrium. Okay, now next part is going to be surgical management. Now next part is going to be surgical management, and in surgical management you already know. So for chocolate cyst, okay, for chocolate cyst, what you are going to do? So we are going to do, if size less than 5 centimeter, so I'm doing cyst aspiration. If size more than 5 centimeter, then we're gonna do cystectomy. Then we are going to do cystectomy. And make sure that you remember, for the recurrent cyst, okay, irrespective of size, if recurrent or then what you will do? So we are going to do cystectomy for recurrent as well. This has been the question asked. Okay, number second thing is, so for adhesions, for adhesions we are going to do adhesiolysis. For adhesions we are going to do adhesiolysis. Okay, so for deposits, for endometrial deposits, we are going to do cauterization and fulguration. Cauterization and fulguration. That's all about the endometriosis. That's all about the endometriosis. Is that clear to everyone? Yes. Now simple. So what is endometriosis? Tissue, endometrial tissue, otherwise else were present. Okay, ectopic endometrium. Okay, now what is the investigation of choice is the question asked. That's gonna be laparoscopy. Age group 25 to 35. Most common site is gonna be ovary. Okay, most common site is gonna be ovary. Second most common site is pouch of Douglas. Second most common site is pouch of Douglas. Remember the laparoscopic findings. Remember the laparoscopic findings of a patient having the chocolate, having the endometriosis is chocolate cyst of the ovary, powdered burn lesions, uterosacral ligament nodularity, adhesions and fibrosis. Adhesions and fibrosis. Okay, most common symptom is going to be dysmenorrhea, that is pain during the menses, followed by that patient is having painful intercourse, dyspareunia and infertility, menorrhagia. Is that clear? PDF I will post in the channel Meduhub. Okay, once we'll finish the session I will post it in the, I'll send it in the group. Clear to everyone, guys? Till then you guys just write down in the comment section, be interactive, just read. Okay, it's a rapid revision session. Okay, you don't need to write anything. I will just send the annotated PDF of part 1 and part 2 in the groups. Okay, I'll send in both Meduhub channel as well as my channel. Okay, clear? You just be interactive and keep answering, and then once we complete the session, go through the PDF. Okay, read it out then multiple times. Now because in the end if we'll still start writing all the things, so because we are in the last lap, 25 days left. Okay, so right now it is better to what, just listen and write, recall whatever you have studied from last 5 months. Okay, then PDF I'll share in the channel, and then go through the PDF, read it out. Clear? Okay, you can read it out at 2x speed as well, watching the video again, so it will be a very useful and efficient revision for you guys. Clear? Chalo. Then followed by that, medical management. So first line is gonna be the OCPs for 3 months. I mean, if a patient wants to conceive, give NSAIDs. Second line, we give the progesterone therapy, sir, orally, so that there will be decidualization of the implants. Okay, and that's why I have mentioned that protective factor for the endometriosis. What will be the protective factor for the endometriosis? Increased levels of progesterone. Okay, then IUCD, Mirena, Okay, we also use injection DMPA, depot medroxyprogesterone acetate. Okay, and this DMPA is also used in one contraceptive, that is Antara. ठीक है ना, do remember this. Antara में होता है DMPA. And how much to use, sir? 150 mg once every 3 months. Third line we have GnRH analogs, goserelin. Okay, now surgical management, chocolate cyst aspiration will do, and tell the patient follow up for the USG as well. More than 5 centimeter will do cystectomy. For adhesions, so we are going to do adhesiolysis. Okay, and for endometrial deposits we're going to do cauterization and fulguration. Cauterization and fulguration. Is that clear to everyone? Clear to everyone, bache? Yes. Now we have one more condition called as adenomyosis. Okay guys, we have one more condition called as adenomyosis. Okay, almost a same like presentation, but there will be uniform enlargement of the uterus. Number first thing. Number second thing, it means the endometrial tissue present within the uterus. So endometriosis interna. Okay, this is also called endometriosis interna. So what does that mean? That means that the endometrial tissue present inside the uterine musculature, inside the uterus, okay, muscles. And what is the definitive treatment? So definitive treatment is hysterectomy. Definitive treatment is hysterectomy. Is that clear? And usually the age group is 40 to 45. That's why almost family is complete. We usually go for what? Hysterectomy. The differential diagnosis of this adenomyosis is fibroid, because at the age of 40-45 fibroids are also most common bacche hai na. And after that, if a patient is having the fibroid, two main symptoms will be again there. So patient can have a dysmenorrhea or the patient can have a menorrhagia. So patient is complaining of heavy bleeding with painful menses at the age of 40-45. So what are your differential diagnosis? Fibroids and adenomyosis. Now how do you differentiate these fibroids with an adenomyosis? So if we talk about an adenomyosis, there is uniform enlargement of uterus. Uniform enlarged uterus. If a question mentions that there is non-uniform enlargement of uterus, your answer goes to fibroids. Your answer goes to fibroids. Clear? So endometriosis, adenomyosis, clear? Okay, now if a patient will complain of dysmenorrhea, menorrhagia, age 40-year-old, along with the uniformly enlarged uterus, what is your definitive management? Sir, hysterectomy. What is your diagnosis? Adenomyosis. Is that clear? Is that clear to everyone? So adenomyosis in a very short manner. Okay, now next one is going to be placenta accreta spectrum. Next one we are going to discuss about placenta accreta spectrum. Now what exactly is this placenta accreta spectrum? As we have discussed last time, that I've told you that this is the placenta, okay, and this is gonna be the layer here called as fibrinoid layer. What is the name of the layer? Nita Bush layer. Fibrinoid layer or Nita Bush layer. Okay, and I have mentioned in the last session that when a patient of uterine inversion was coming to me with the upside down of the uterus, the cause of an uterine inversion can be badly adherent placenta. Okay, badly adherent placenta. Now we'll discuss what exactly was that adherent placenta. So it's called as placenta accreta spectrum. Okay, so what is placenta accreta spectrum? When the placenta is firmly adherent, when the placenta is firmly adherent to uterine wall, when the placenta is firmly adherent to the uterine wall. Okay, now this placenta is totally attached with the uterine wall. Now due to the absence, so what is the reason? Okay, due to the absence of decidua basalis, due to absence of decidua basalis and fibrinoid layer. And what is the fibrinoid layer called? So this fibrinoid layer is called as Nita Bush layer. This fibrinoid layer, it is called as Nita Bush layer. This is called as Nita Bush layer. This fibrinoid layer is called as Nita Bush layer. Okay, now when this fibrinoid layer is absent, my dear students, this placenta, it started to go towards the myometrium. It is going towards the myometrium. It is going towards the myometrium. Now depending upon the magnitude, depending upon the invasion, now we have three types. We have accreta, we have increta, we have parcreta. Very simple manner to learn. Sir, A is accreta, that means it is attached to myometrium. It is attached to myometrium. Sir, I means increta, that means it is invading the myometrium. It is invading the myometrium. Sir, P, parcreta, that means it is going till the pelvic structures like bladder. So easy way to remember, A, I, P. Sir, A, it is attached to the myometrium. Sir, I, it is invading the myometrium. And P, it is going to the pelvic structures. It's going to the pelvic structures. And what are the pelvic structures? Usually the most commonly it is involving, that's gonna be bladder. Okay, so write it down. Sir, we have three types. Okay, we have placenta accreta, we have placenta increta, we have placenta parcreta. We have placenta increta, accreta, and parcreta. So placenta accreta means it is attached to myometrium. So placenta increta means it invades the myometrium. And placenta parcreta means it invades through serosa and goes till the pelvic structures. And what are the pelvic structure mostly it is involving? It's involving bladder. Okay, that means it invades through serosa. Through pelvic structures like bladder. So we have increta, accreta, and parcreta. We have increta, accreta, and parcreta. Clear to everyone? Okay, now what is investigation of choice? What is investigation of choice we usually do? We go for USG with Doppler. Okay, we go for USG with Doppler. And what is the gold standard? What is the gold standard? That is gonna be MRI. To know exactly where the tissues are, okay, we go for the MRI. Okay, and what will be the treatment asked? Sir, if they are asking management, if they are asking the management is going to be obstetric hysterectomy. The management is obstetric hysterectomy. Okay, so that's all about the placenta accreta spectrum. Okay, what are the risk factors for this? So usually the risk factor is placenta previa or the previous cesarean section. Okay, do remember, if it is attached to myometrium, it is placenta accreta. If it is invading the myometrium, it's placenta increta. And if it is going through serosa till the pelvic structures, it is the placenta parcreta. It's a placenta parcreta, and this all together is called as morbidly adherent placentas, AIP. Is that clear to everyone? Clear to everyone what exactly is placenta accreta spectrum? What exactly is placenta accreta spectrum? Clear? Yes, bache? Okay. Now, if a question will be asked, a 35-year-old gravida 4 para 3, she has a history of previous cesarean deliveries. Okay, and it's found to have an anterior placenta previa on routine ultrasound at 28 weeks of gestation. Doppler suggests that there is an abnormal placental attachment, okay, with the loss of retroplacental hypoechoic zone and placental tissue appearing to invade the bladder wall. Now, my dear students, I've already said in before that first thing, it has a risk factor of a placenta previa or a previous cesarean section. So a female, she already had 3 previous cesarean deliveries. Okay, 3 previous cesarean deliveries. Okay, and after that the Doppler suggested that, that's why the investigation of choice, USG with Doppler, to exactly know the blood flow. Okay, the Doppler suggested that there is an abnormal placental attachment. There is an abnormal placental attachment with the loss of retroplacental hypoechoic zone, and this tissue is appearing and invading the bladder wall. So if it is going till the bladder wall, if it is going invading the serosa till the pelvic structures, the answer goes to which one? Everyone write down the answer in the comment section. Very good. Sir, P for pelvic structures, P for parcreta. What is the exact answer? Sir, placenta parcreta. Okay, what is the management? Obstetric hysterectomy. What is the gold standard investigation? MRI. Okay, what is the exact reason? Due to the absence of decidua basalis and the fibrinoid layer. So it is all about the placenta accreta spectrum. Okay, the next question. Okay, usually ask the drugs for medical abortion. Okay, now we have discussed abortion, everything about the abortion. Okay, now what are the medical drugs? Write down in the comment section. Yes, you know that 2 drugs are there, mifepristone and the misoprostol. So tell me what exactly is the dosage of mifepristone and what is the dosage of a misoprostol. Yes, what will be the answer for this one? Mifepristone and misoprostol. Yes, mifepristone and misoprostol. Very good. The answer is mifepristone 200 mg followed by misoprostol 800 micrograms after 48 hours. After 48 hours. Okay, now if we talk about the period of gestation, okay, and method of MTP, if less than 7 weeks, remember my dear students, if less than 7 weeks, okay, we go for medical drugs. We go for medical drugs for the abortion. Now what are these medical drugs? These medical drugs, mifepristone and misoprostol. Okay, so what is a mifepristone? It is an anti-progesterone. And what is misoprostol? It is a prostaglandin E1. Okay, and it exactly does what? It expels the fetus out. What is mifepristone? It kills the fetus. Okay, now if it is 7 to 12 weeks, if it is 7 to 12 weeks, we go for suction and evacuation. We go for suction and evacuation. Okay, and if more than 12 weeks, we go for prostaglandins. We go for prostaglandins. Okay, now if we talk about the medical abortion, Government of India says that as per the GOI, you can go for medical abortion till 7 weeks. You can go for medical abortion till 7 weeks, and WHO says that you can go till up to 9 weeks. Okay, up to 9 weeks. Now how exactly to give these 2 drugs, mifepristone at misoprostol? Okay, now if a patient is having less than 7 weeks induced abortion, okay, at less than 7 weeks we are going to use our medical management. Yes sir. Okay, but 7 to 9 weeks also will use the medical management, but the difference will be in the dosage. Okay, now on day one we are giving a drug, tab mifepristone. Sir, how much to give mifepristone? We'll give 200 mg. Okay, at less than 7 weeks we'll give tab mifepristone 200 mg. Okay, then followed by that on day 3, that means after 48 hours, after 48 hours we are giving a drug tab misoprostol. And how much to give? So we'll give 400 micrograms. Okay, if it is less than 7 weeks, you'll give 400 micrograms. If more than 7 weeks, 7 to 9 weeks, you have to give exactly 800 micrograms. It comes with a kit. Okay, 5 drugs are there. 1 tablet of mifepristone 200 mg followed by 4 tablets 200 micrograms each of misoprostol. So what exactly is the function of this mifepristone? So it is an anti-progesterone. It will kill the fetus. So what exactly is the function of the misoprostol? So it expels the fetus out. It expels the fetus out. Clear? Clear, bache? It expels the fetus out. Now followed by that on day 15, followed by that on day 15, you have to go for an USG. Okay, you have to go for a USG to check whether the process is complete. Whether the process is complete. And while going for the medical abortion, a patient usually bleeds for 2 weeks, है ना? Patient bleed करता है for how many weeks? So patient usually bleed for 2 weeks. Patient usually bleed for 2 weeks. Okay, that is about at less than 7 weeks. Now if a patient is there 7 to 9 weeks, at 7 to 9 weeks, at 7 to 9 weeks. Okay, 7 to 9 weeks, number first thing, so tab mifepristone, same, we are gonna do same mifepristone 200 mg. Okay, but misoprostol you will give 800 micrograms. Okay, and followed by that you will again go for USG to ensure that process is complete, because if the retained products of consumption will be inside, okay, if those retained products of consumption will be inside, you have to go for curettage, and curettage has a complication because there will be scar formation and they will lead to the adhesions, synechial formation. The syndrome is called as what? Write down in the comment section. The syndrome is called as, yes, we have discussed, the syndrome is called as Asherman syndrome. The syndrome is called as Asherman syndrome or uterine synechial. And what will be the treatment? Okay, what will be the treatment? The treatment is going to be hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis. Is that clear? Hysteroscopic adhesiolysis. Clear? Okay, so it's all about the medical abortion. It's all about the medical abortion. Clear? So remember, tab mifepristone 200 mg, 200 mg. Okay, now only difference, if they ask less than 7 weeks, make sure that if less than 7 weeks is in the question, you mark 400 micrograms. If nothing is given, directly mark 800 micrograms, just like this question. So mifepristone, it's an anti-progesterone. Misoprostol, it's prostaglandin E1, okay, and it expels the fetus out. It expels the fetus out. Okay, next question. A 28-year-old woman reports experiencing the sharp localized lower abdominal pain, which occurs consistently midway through her menstrual cycle. The pain resolves within a few hours. She has no other symptom. What is the most likely diagnosis? Now, you know, guys, a patient is complaining of a dysmenorrhea pain. It's during the menses, but this time it is not during the menses. It's exactly the midway. It is exactly the midway. That means on the day 14. You can suspect that it is an ovulation day. So the pain during the ovulation, in simple words, the pain during the mid-cycle or the pain during the ovulation, it is called as mid-cycle pain, or very good, it's called as mid-cycle pain or Mitchell-Marsh pain. It's called as mid-cycle pain or Mitchell-Marsh pain. Okay, followed by that, let's discuss what are the different types of a dysmenorrhea, okay, and what exactly are the differences about each of the following. Now, my dear students, if I talk about dysmenorrhea, we have different types. We have primary, we have secondary, okay, we have membranous, Now what is dysmenorrhea, sir? Dysmenorrhea means pain during menses. It means pain during the menses. Okay, now if we discuss the first type, that is primary dysmenorrhea. If we talk about primary dysmenorrhea, what is primary dysmenorrhea? It is also called as spasmodic dysmenorrhea. It's also called as spasmodic dysmenorrhea. In primary dysmenorrhea, the pain begin with menses or just 10 minutes or 1 hour prior to menses, okay? And it will just resolve on the same day. So write it out. So pain begins with menses or before or just before menses. Or just before menses. Okay, and remember, this pain, it's usually due to the prostaglandins. Due to prostaglandins, and it resolves within 48 to 72 hours. And this pain resolves within 48 to 72 hours. Okay, that is about primary dysmenorrhea. Okay, now second one is secondary dysmenorrhea. Secondary dysmenorrhea. Now the secondary dysmenorrhea, sir, this secondary dysmenorrhea, it's also called as, क्या बोलेंगे इसको और sir, it's also called as congestive dysmenorrhea. It's also called as congestive dysmenorrhea. Okay, now the pain begins 2 to 3 days prior to the menses, and it will remain throughout the cycle. That is a classical feature of a secondary dysmenorrhea. And this secondary dysmenorrhea, it is due to the systemic pathology, like if a patient is having a PID, like if a patient is having endometriosis. So these all things have a classical dysmenorrhea called as secondary dysmenorrhea. So right, pain occurs 2 to 3 days before menses, okay, and remain after and remain throughout the cycle. And remain throughout the cycle. This pain, it's due to the systemic pathology, due to pelvic pathology. The pain is due to pelvic pathology. What is the pelvic pathology that is usually associated? Endometriosis or PID? Endometriosis or PID. So it's due to endometriosis or PID. Okay, next type of pain is membranous dysmenorrhea. Next is membranous dysmenorrhea. Now what exactly is this membranous dysmenorrhea, bache? So in a uterus there is a fibrinolytic system, okay, which will stop or which will do less clumping of the blood or less clot formation of the blood. Now if this system is absent, what will happen? Eventually the more clots will be there, and when the more clots will be there, it needs more contractions to pass these clots out. Okay, when it needs more contraction to pass these clots out, it will cause more pain. Such a pain due to the absence of the fibrinolytic system in the uterus is called as membranous dysmenorrhea. Okay, so remember that fibrinolytic system is responsible Okay, so I will write in very simple manner: absence of fibrinolytic system in uterus. There will be more clots, there will be more contractions, and eventually there will be more pain. Eventually there will be more pain. Eventually there will be more pain. That is called as membranous dysmenorrhea. Okay, and last one, the mid-cycle pain that we have already discussed. What is a mid-cycle pain? So mid-cycle pain, that is Mitchell-Mersch pain, which is also called mid-cycle pain. Okay, what is the reason of this mid-cycle pain? There is an accumulation of blood or debris in the pouch of Douglas, which causes this pain, called as Mitchell-Mersch pain. So write it down. So it's pain due to accumulation of blood and debris pain due to blood and debris accumulated in pouch of Douglas during the time of ovulation. During the time of ovulation. That's about the Mitchell-Mersch pain. That's about the Mitchell-Mersch pain. Is that clear? Okay. Clear guys? Dysmenorrhea and the types of dysmenorrhea. And this blood and debris, usually it's coming from the follicles, है ना? कहाँ से आता है ये? Follicles से. At the time of ovulation, and this is getting accumulated in the pouch of Douglas, and the pain is called as mid-cycle pain or Mitchell-Mersch pain. So it's called as mid-cycle pain or Mitchell-Mersch pain. So it's all about dysmenorrhea and the types. Okay, now very more important question or important topic that usually they ask, it's gestational diabetes mellitus. Okay, gestational diabetes mellitus. Now if I talk about GDM, my dear students, it usually occurs around 24 weeks. It usually occurs around how many weeks? Around 24 weeks. Now sir, if a patient is having 14 weeks and increase blood sugar levels, what I will call? So pre-existing sugars. After 24 weeks, I call it as GDM. Okay, pre-existing sugars, that means before the pregnancy or prior to the 24 weeks, I will call it as the pre-gestational or overt diabetes mellitus. So what I will call it as? Pre-gestational or overt pre-gestational or overt diabetes mellitus. Overt diabetes mellitus. So always remember, around 24 weeks, if they ask, around 24 weeks, if they ask what is the investigation of choice, okay, at 24 weeks, if they ask, a patient is coming for the antenatal checkup, okay, what are the investigations or what is the investigation likely you will do around 24 weeks? So what will be your answer around 24 weeks? So what will be the answer? So we are going to do the one-step test or 75 grams glucose tolerance test, oral glucose tolerance test. So what is the reason for this gestational diabetes mellitus? Okay, now you know that it occurs due to two hormones mainly. What are the two hormones? Sir, HPL and estrogen. So it's usually due to two hormones called as HPL and estrogen. Okay, and HPL and estrogen, they have an insulinase like action. Okay, so they act as an insulin, so they will cause insulin resistance, so they will induce insulin resistance. Okay, due to which there will be increased blood sugar. Due to which there will be increased blood sugar. So simple, sir, two hormones two hormones. What are the two hormones? HPL and estrogen. So they induce the insulin resistance, which causes increased blood sugar levels, Now if a patient is already diabetic, that's called as overt diabetes. Okay, now what will be the investigation in a patient having a overt diabetes? So we'll go for HbA1c. So we'll go for HbA1c, and more than 6.5 will be a confirmatory, that is the patient is having a diabetes. Or for the this is for the long term 3 months. For the short term we check the levels. Which levels we check? Anyone in the comment section? Short term के लिए कौन सा level check करेंगे? Don't write fasting blood sugar. Don't write FB, fasting blood sugar, or don't write fasting blood sugar or RBS. Yes. What will be the treatment? Sorry, what will be the investigation? What will be the investigation? Sir, serum fructosamine levels. Serum fructosamine levels. Just a second, let me get it correct. Serum fructosamine level. Okay guys, audible? Okay, write down in the comment section guys, audible? Okay guys, audible? Chale. So we'll check the serum fructosamine levels. For the short term, serum fructosamine levels. For a long term, HbA1c. Okay. Now, sir, for GDM patients, gestational diabetes patients, what will be the investigation? So we go for a 75 grams of sugar. We go 75 grams. It's called as one-step test. That will give 75 grams of sugar, glucose. Okay. टू स्टेप में क्या देते हैं? 2 बार 50 and 100. यहाँ पे कितना देते हैं? 75 grams. Okay. So fasting should be less than 92. At 1 hour, it should be less than 180. 2 hour, it should be less than 153. Okay. So remember, fasting less than 92. 1 hour less than 180, and 2 hour less than 153. And anyone abnormal value, anyone abnormal value is diagnosis of GDM. Is diagnosis of GDM. Anyone abnormal value is diagnosis of GDM. Now, can you tell me, for overt diabetes, what should be the level of RBS? Okay. Now, if a patient is over diabetes, what should be the level of the blood sugar in RBS? Write down in the comment section. It is a NEET PG PYQ. RBS for overt diabetes. RBS for overt diabetes. How much should be the blood sugar levels for overt diabetes? How much should be the random blood sugar levels for a patient having overt diabetes? Yes, everyone in the comment section, please. So NEET PG PYQ, what should be the levels of RBS in overt DM? Sir, it should be more than how much? So it should be more than 200 mg per deciliter. It should be 2 weeks, not less than 140. For confirmation, it should be more than 200, then only you can say that diagnosis of GD overt DM. Okay, MEFI mesot around 2 weeks. Okay, bleeding रहता ही रहता है in the medical management. For the suction and evacuation, no bleeding. ठीक है, USG guided suction and evacuation, bleeding नहीं होता usually. Now effects of diabetes on mother. Now effects of diabetes on mother. So write down in the comment section what will be the effect of diabetes on mother. First of all, we already know that in case of a JDM there is a macrosomic baby, that means more than 4 kg. Now when the baby is more than 4 kg, can I write down? So there are increased chances of cesarean section. Yes bache. So there are increased chances of cesarean section. Followed by that, sir, there will be postpartum hemorrhage. Due to the over distension of the uterus, the tone of the uterus will be decreased. As discussed in the first part, so postpartum hemorrhage, the most common cause will be atonic uterus. And what is the reason for the atonic uterus? That means what is the reason for the decreased tone of the uterus? That means there is an over distension of the uterus. The uterus is large, and which condition the uterus will be large? When the baby will be big. Baby will be big in the gestational diabetes mellitus, polyhydramnios, in pregnancy. So here as well we can write that effect on a mother can have postpartum hemorrhage. Mother can have postpartum hemorrhage. Okay, also क्या हो सकता है? Birth canal injuries. Okay. Now what will be the effect on the baby? So baby, you already know that baby we can have a shoulder dystocia. On baby, if I write on baby, what will be the effect on the baby? Baby will have shoulder dystocia. क्या होगा बेबी को? Shoulder dystocia. And what exactly is this shoulder dystocia? Sir, the shoulder dystocia means when there is a delay in the delivery of the shoulder after coming out head by 1 minute. Okay, that is called as shoulder dystocia. उसको क्या बोलेंगे? Shoulder dystocia. So delay in the delivery of the shoulder by 1 minute after the delivery of the head, that means shoulder dystocia. And for the shoulder dystocia, okay, for the shoulder dystocia, what is the maneuver that we use? For the shoulder dystocia, the maneuver that we use is Macrobert's maneuver. Okay, the maneuver that we use is Macrobert's maneuver. So is that clear? Macrobert's maneuver. Now other maneuvers. Sir, what are the other maneuvers that we have? We have Wood corkscrew maneuver. Just remember the names. Wood corkscrew maneuver. We have Gaskin's maneuver. We have Zamanelli maneuver. Clear to everyone? Okay, these are the other maneuvers that we have in case of shoulder dystocia. Clear to everyone? Now, my dear students, now what can be the problems of the newborn due to the diabetes? Now, in the beginning, baby is hyperglycemia. Okay, in a neonatal life, in a fetal life, baby is what? Baby is hyperglycemia. But due to the beta cell pancreas hyperplasia, okay, and due to the healthy pancreas of this baby is having hypoglycemia. So this has been the question asked: if a mother is having hyperglycemia, what is the reason that the baby is having hypoglycemia? So it is due to the hyperplasia, increased number of cells. It is due to the hyperplasia of beta cells of pancreas. It is due to the hyperplasia of beta cells of pancreas. If they ask fetal फीटल में होता है फीटल हाइपरग्लाइसीमिया, बट लेटर, वेरी गुड, लेटर ऑन इट इज हाइपोग्लाइसीमिया. सो न्यूनेटल हाइपोग्लाइसीमिया बट फीटल hyperglycemia. Clear? Okay, and then you already know that during the increased level of sugars in the baby, the urine is more, है ना, urine more की वजह से, that's why the GDM baby is having, GDM mother is having a polyhydramnios. The GDM में क्या होता है, polyhydramnios. Okay, now hypoglycemia will be there, there will be hypocalcemia, there will be hypocalcemia, there will be polycythemia, there will be polycythemia and hypomagnesemia. And hypomagnesemia. Is that clear? Is that clear? So these are all the problems in the newborn. These are all the problems seen in the newborn babies. Okay, clear to everyone? Yes. Now followed by that, what are the anomalies that are seen? Sir, most common anomalies that are seen will be CVS followed by CNS, cardiovascular system anomalies followed by CNS. Okay, now if we talk about the most specific is transposition of great arteries, TGA, but also seen with the GDM. We have VSD, we have patent ductus arteriosus, we have VSD and PDA. Okay, now if I talk about the neural tube defects that are most specific, that is going to be caudal regression syndrome. And this caudal regression syndrome, my dear students, it's also called as sacral agenesis. It's also called as sacral agenesis. And this sacral agenesis, classical picture, abnormal lower limbs. Okay, this is sacral agenesis or caudal regression syndrome or caudal regression syndrome. Okay, now what are the other neural tube defects which are also seen? So other neural tube defect that can be seen is anencephaly. Okay, failure of the closure of anterior neural port on day 25. Day 25 याद रखियो, ठीक है. Classical two signs seen in anencephaly, frog eye sign. They can ask this frog eye sign and Mickey mouse sign. I have not added the radiological picture of these two things, but they can ask, because last time they asked, there are two classical signs seen in spina bifida. The most common neural tube defect is spina bifida. Usually neural tube defect कब होते हैं? B9 deficiency. That's why folic acid is mandatory in the pregnancy. Okay, as per the anemia Mukt Bharat, how much folic acid to be given? 500 micrograms. And how much iron to be given? 60 mg of iron. Okay, now tell me, there are two signs seen in the spina bifida. Most common spina bifida, if asked, spina bifida occulta. Okay, what exactly you need to check in the amniotic fluid to confirm that yes, the patient can have a neural tube defect? Acetylcholinesterase. And tell me, what are two signs seen with spina bifida in the cerebellum? The two signs are lemon sign and banana sign. Okay, lemon sign and banana sign. Clear to everyone? Lemon sign and banana sign. Okay, and in anencephaly, frog eye sign and Mickey mouse sign. Frog eye sign and Mickey mouse sign. Okay, now what will be the management? First management will be, again guys, lifestyle modification. So you will write, so management is going to be diet modification. So management is diet modification. Okay, followed by that, drug of choice. Drug of choice is insulin. Okay, and if we talk about the oral hypoglycemic, we have metformin and glyburide. Is that clear? One question was asked, metformin side effect, lactic acidosis. Glyburide was asked. It's a class of a drug called as sulfonylureas, and it was mentioned after the gym, a diabetic patient fell down, and the blood sugar levels were 45. What can be the class of drug responsible for this condition? Your answer goes to glyburide, which is a sulfonylurease. So sulfonylurease have a side effect of hypoglycemia. Is that clear? Which anti-diabetic drug are responsible for the urinary tract infection? Okay, SGLT2 inhibitors, gluflozins. Okay, flozins. Now next is shoulder dystocia. The question has been asked multiple times on the shoulder dystocia. Okay, they can ask delay in the delivery of shoulder by 1 minute, or by 2 minutes, about 3 minutes, or 5 minutes. Remember that it's 60 seconds delay in the delivery of the shoulder by 1 minute. Delay in the delivery of shoulder by more than 1 minute after delivery of head. After delivery of head. After delivery of head. Okay, now first of all, call for the help. Okay, first of all, you will call for the help, followed by that you will evaluate for episiotomy. You will evaluate for episiotomy. Sir, what exactly is episiotomy? It's a planned incision. It's a planned incision on perineum. It's a planned incision on the perineum, so that the widening of the birth canal will be there. Okay, so that there will be, it's done in case of a shoulder dystocia, it is done in case of an obstruction, it's done in case of an breech presentation, है ना, जब breech lower segment में होगा, so that the birth canal opening should be widened. Okay, bigger. Okay, so we'll evaluate for episiotomy. I will mention the question related to episiotomy as well. What are the structures that are resected, and what are the structures that are not resected? Okay, what is an advantage of a mediolateral over the midline? Okay, so they'll be discussing in few minutes. Followed by that, we go legs hyperflexion. This is what you call McRoberts maneuver. Okay, then we'll put a supra pubic pressure. Okay, then internal rotation, remove the posterior arm, roll the patient to hands and knees. Okay, this is a mnemonic for shoulder dystocia. Now this classical maneuver, when the legs are flexed into the abdomen, which will cause the rotation of the pelvis, okay, and the opening of the birth canal. Followed by that, we'll put the suprapubic pressure over here. Okay, you see, first, so there is a flexion, legs are flexed. This is a first step. Second step, so we are putting pressure, okay, so that this will be pressure will be applied on the anterior shoulder, and then remove the arm. Okay, now my question to you, 3 questions, 1, 2 and 3. Okay, first question, my dear students, what is the most common fetal complication of shoulder dystocia? Most common fetal complication of shoulder dystocia. So most common fetal complication of shoulder dystocia will be, anyone? Most common location of shoulder, most common complication of shoulder dystocia for fetal will be, so there will be a brachial plexus injury, C5, C6, that is Erb's palsy. Okay, one question was asked, roots of Erb's palsy क्या है? C5, C6, C5, C6. Okay, if a question will be asked, what is the most common maternal complication? What is the most common maternal complication of shoulder dystocia? Maternal में क्या होगा? Postpartum hemorrhage. So maternal complication will be postpartum hemorrhage. Maternal complication will be postpartum hemorrhage. And if the question is most common nerve injured, most common nerve injured, your answer is, what will be the answer? Most common nerve injured, it's going to be lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. Clear? Is that clear? Lateral cutaneous nerve of thigh. Okay, so most common fetal complication, Erb's palsy, maternal, postpartum hemorrhage, And the nerve which is injured, it's lateral cutaneous nerve of thigh. It's lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. Now, bache, tell me a 32-year-old multigravida. A 32-year-old multigravida at 30 weeks of gestation, she's been diagnosed with a GDM, gestational diabetes mellitus. Now, blood glucose level is managed by the insulin. She's on insulin. Okay, she is on the insulin. On follow-up, the fetus is large for gestation. Large for gestation, more than 90 centile, and it's a macrosomic baby. Okay, 10 to 90, appropriate. Less than 10, okay, IUGR. And the ultrasound shows the polyhydramnios. It's already discussed that JDM में क्या होता है? Polyhydramnios, because the fetal urine is the main component of an amniotic fluid, and JDM में fetal urine ज़्यादा हो जाता है, तो eventually amniotic fluid is more, which is called polyhydramnios. Which of the following complication is least expected? Less likely you will see the condition among the following options in a patient having a JDM. Shoulder dystocia during the delivery, yes sir. Because the baby is big, we go for a normal vaginal delivery. There can be a delay in the delivery of the shoulder by more than 1 minute. Neonatal hypoglycemia, yes sir. After the baby is born, there is neonatal hypoglycemia after the birth due to the beta cell pancreas hyperplasia and the healthy pancreas of the baby. Postpartum hemorrhage, yes sir. Postpartum hemorrhage will be there because the tone of the uterus is decreased due to the big baby, the over distension of the uterus. Sir, IUGR, no, baby is not IUGR there, rather than baby is macrosomic. Rather than baby is macrosomic, and macrosomic baby is more than 4 kg. Macrosomic baby is more than 4 kg. Clear? Clear? Is that clear to everyone? Is that clear to everyone? That's all about gestational diabetes mellitus. That's all about gestational diabetes mellitus. Clear? Yes, sir. Let's move to the next topic. So do remember JDM, oral hypoglycemics, metformin, glyburide. Do remember the most common fetal complication of palsy, shoulder dystocia. Okay, they will mention which of the following is incorrect. So what is incorrect? They will mention fundal pressure. No, it's a suprapubic pressure. Some people include it in the MacRoberts manual. Some books do not include it. Okay. Okay. Upper diet modification, insulin drug of choice. Okay. Remember there is neonatal hypoglycemia and there is fetal hyperglycemia. अगर fetal में दिया हुआ है तो hyperglycemia, neonatal में दिया हुआ है तो hypoglycemia. Okay. Remember MacRoberts manual. One step test. क्या 75 grams of sugar glucose. This is also the question asked. Okay, it occurs around how many weeks? 24 weeks. Two hormones responsible usually causing insulin resistance, HPL and estrogen. Okay, now let's move to the next topic. Everything is clear so far? Write down in the comment section. Everyone out there, all good? All clear? Yes? Yes sir, all clear. Are you able to recall, guys, from whatever you have studied so far from the main notes? Yes sir. Okay, good. Now let's begin with the next chapter, eclampsia or hypertension in pregnancy. Now let's begin with the next chapter, hypertension in pregnancy. Okay. If in case any doubts, feel free to ask, ping in the comment section, guys. Okay, if later on still you guys can ping in the telegram. Okay, so I'll get back to you. Okay, chalo, I have included all the important chapters. No, prior to that. First visit only. Chalo, hypertension in pregnancy. Now, if you talk about the classification, okay, first of all, chronic hypertension. Chronic hypertension means pre-existing hypertension. Now, hypertension usually occurs around how many weeks? Around 20 weeks. Okay, usually around 20 weeks. When we talk about PIH, pregnancy induced hypertension, when we talk about pregnancy induced hypertension, it is usually around how many weeks? It's usually around 20 weeks. Sir, if it is prior to that, if a pregnancy induced hypertension, or if a patient is having a hypertension prior to that or pre-existing, we call it as a chronic hypertension. तो क्या बोलेंगे इसको बच्चे? So we call it as a chronic hypertension. So it means the hypertensive at the start of pregnancy, hypertensive at the start of pregnancy, it's a known case of essential hypertension, okay, which continues more than 12 weeks postpartum. Okay, so patient who's already having a hypertension and this hypertension will remain after the pregnancy 12 weeks, we call it as chronic hypertension. Clear? Now what is gestational hypertension, sir? Gestational hypertension means hypertension more than 20 weeks of gestation, okay, in a previously normotensive woman with no proteinuria, and it will resolve less than 12 weeks postpartum. This is called as gestational hypertension. Or we can write one more thing, no proteinuria on 2 occasions. You have to see that blood pressure is increased on 2 occasions more than 140/90. Okay, on 2 occasions more than 140/90, 6 hours apart, 4 to 6 hours apart, that is called as gestational hypertension. So if a patient is before, prior to that 17 weeks, you can write it is pre-gestational hypertension, okay, but there is no proteinuria associated. Now if a patient is coming to you with a blood pressure of more than 140/90 after 20 weeks with a proteinuria of more than 300 mg per 24-hour urine, or urine dipstick is 1+. Now this is called as pre-eclampsia. तो क्या बोलेंगे बच्चे? So it is called as pre-eclampsia. It is called as pre-eclampsia. And if in case a patient is having, okay, if in case the patient is having seizure along with the pre-eclampsia, it is called as eclampsia. It is called as eclampsia. Clear to everyone? Okay, is that clear to everyone? Yes. So classical definitions. So chronic hypertension, if a patient is already having a hypertension. Okay, what is gestational hypertension? So patient having a hypertension more than 140/90 in a previously normotensive woman. Normal woman, she did not had any episode of hypertension before, and now in pregnancy she is having 140/90, more than that blood pressure at 20 weeks onwards, that is a gestational one. If the proteinuria is there, protein in the urine more than 300 mg per 24-hour urine, it is called as pre-eclampsia. And if there are seizures associated, generalized clonic-tonic seizures, this is called as eclampsia. This is called as eclampsia. Clear? Okay, now we'll learn what exactly is the management for this particular condition. Number first thing. Number second thing is that what are the classical signs when there is an toxicity of some drugs, and what are the safe antihypertensive treatment. Clear? Okay, now sir, first of all, if we talk about eclampsia, the first management of eclampsia, anyone in the comment section, what is the first management? If they ask what is the first management in eclampsia, what will be your answer for the first management in eclampsia? So the answer goes to yes, airway management. Don't mark magnesium sulfate or labetalol. Always make sure the first answer that you will choose, if they ask the first management, your answer should be airway management. Second, MgSO4. Third, IV antihypertensive, IV labetalol. Fourth, delivery. Okay, fourth will be delivery. First, airway management. Second one will be the magnesium sulfate. Third one will be the antihypertensive IV. Fourth one is going to be delivery, NVD. Okay, now if we talk about the drug of choice for eclampsia when the patient is having blood pressure more than 140/90 along with the seizures, it is going to be magnesium sulfate. Okay, the question was asked, what should be the magnesium levels in the body to give magnesium sulfate? You have to maintain the magnesium levels 4 to 7 milli equivalent. Make sure that if it goes beyond that, the toxicity will start. Okay, अगर उससे ज़्यादा हो रहा है तो what will happen बच्चे? So the toxicity will happen. The first sign of the toxicity, the question was asked, first sign of magnesium sulfate toxicity, there will be loss of deep tendon reflexes. There will be loss of deep tendon reflexes, or they can mention in the comment section, they can mention in options loss of patellar reflexes, okay, or they can mention sluggish knee jerks. Sluggish knee jerk, this is the first sign of a magnesium sulfate toxicity. Now how exactly we are giving this magnesium sulfate, bache? So if we are giving intramuscular plus intravenous, okay, intra, yes, loss of knee jerk. If we are giving intramuscular plus intravenous, this regime is called as Pritchard's regime. This regime is called as Pritchard's regime. And if in case we are giving intravenous only, this is called as Zuspan regime. This is called as Zuspan regime. We have discussed in a detail what exactly is intramuscular regime plus intravenous and IV. What is loading dose, maintenance dose in the main classes. So do check that as well. Okay. Then we have also discussed before giving magnesium sulfate what are the things you need, what are the parameters you need to check. Okay. Okay. And after that, what exactly you need to check. Clear? Now followed by that, if a patient is having now magnesium sulfate toxicity, there will be loss of deep tendon reflexes, then there will be decreased urine output, then there will be respiratory paralysis, then the cardiac arrest. Okay, the antidote given is going to be, if they ask antidote given, that's going to be calcium gluconate. That's going to be calcium gluconate. Okay, that's going to be calcium gluconate. Now my dear students, if we talk about what exactly is the main reason that the patient is having the hypertension in pregnancy. So if we talk about the pathophysiology, in one word, what exactly is the reason? Now you know around 20 weeks the trophoblastic invasion takes place. Okay, the trophoblastic invasion takes place. Now at 20 weeks, when there is incomplete trophoblastic invasion, okay, when there is incomplete trophoblastic invasion, the resistance in vessels will remain high because they are not replaced. The smooth muscle spirals arteries are not replaced. Okay, the lumen is still narrower. Okay, the blood flow is still, vasospasm is still there, due to which there will be increased blood pressure. If in case patient had a complete trophoblastic invasion, okay, the resistance will have been low. Okay, the blood flow would have been more. Okay, and the lumen size would have been bigger, so that there would not be any high resistance. But due to this incomplete trophoblastic invasion, what is happening? Increase blood pressure, or you can write vasospasm. Vasospasm here rehta hai. Okay, and that's why the drugs like furosemide and all, they are contraindicated. Now what are the drugs we can give, sir? What are the drugs we can give? First of all, we can give oral labetalol. Labetalol is an alpha plus beta blocker. Okay, it's safe. We can give alpha methyl dopa. We can give alpha methyl dopa. We can give hydralazine, which is an arteriolar dilator. We can give nifedipine, it's a calcium channel blocker. We can give prazosin alpha 1 blocker, which is an alpha 1 blocker. Okay, all these drugs. Okay, remember nifedipine, if given sublingual, is contraindicated because it can cause sudden hypotension. Prazosin, you also remember, alpha 1 blocker, having a side effect of tremors along with the orthostatic hypotension, and this is also used as an antidote for scorpion sting, and also used in a benign prostate hyperplasia. ठीक है ना? Hydralazine is an arteriolar dilator, and alpha methyl dopa is a prodrug. Okay, so this is all about the hypertension management. If asked orally, बच्चे, first answer will be this, and if labetalol in option, your second choice goes to alpha methyl dopa. Okay, now if we talk about the emergency drug of choice for hypertensive emergencies, and then your answer should be IV labetalol. So IV labetalol 20 mg give. Okay, and you can give up to 220 mg, 20 बढ़ा के दे सकते हैं up till 220 IV labetalol. If labetalol is not over there, For emergencies, you can give IV hydralazine. You can give IV hydralazine. Is that clear? Is that clear? So it is all about the eclampsia. It's all about the eclampsia and hypertension in pregnancy. Now, when in preeclampsia, there is a decreased blood flow to the organs. Okay, imminent eclampsia. Okay, now what happens? Blurring of vision will be there, headache will be there, neck stiffness will be there. Okay, and when this decreased blood supply to the organs is going on, when the decreased blood supply to the kidney goes, the GFR will be decreased. When the GFR of the kidney is decreased, the urine formation will decrease. When the urine formation will be decreased, as discussed earlier, that this urine is a main component of an amniotic fluid. जब GFR ही कम हुआ, urine कम हुआ, तो eventually patient will have oligohydramnios. So one cause of oligohydramnios, you remember, that is preeclampsia. One cause of polyhydramnios, you remember, GDM. Okay. Now the same way, there is a decreased blood supply to the brain. When there is a decreased blood supply to the brain, it causes cerebral hypoxia, and due to that cerebral hypoxia, the mother is having seizures. Okay. That's why in a prophylaxis, when a patient is having preeclampsia, we start what? Magnesium sulfate in order to prevent what? Eclampsia. वो dilatation कराएगा, more blood flow to the brain, more blood flow to the kidneys in order to decrease the complications. Clear to everyone? Okay, so that's all about preeclampsia and eclampsia. ठीक है ना? Clear? So do remember about the definitions they will mention. Okay, how much should be the blood pressure? More than 140/90. Around how many weeks? 20 weeks. Okay, pathophysiology, your incomplete trophoblastic invasion or vasospasm. First management, airway. Second management, IV magnesium sulfate. Third management, antihypertensive. Third step, I will call it. And fourth one is delivery. Fourth one is delivery. Okay, now at 28-year-old, gravida 3 para 1 abortion 1 at 33 weeks of gestation, she came to the clinic for an antenatal checkup. My dear student, she's coming there just for antenatal checkup. She's a known case of preeclampsia which is diagnosed at 26 weeks. She's a known case of preeclampsia diagnosed at 26 weeks. Okay, now her blood pressure is her blood pressure is 130/90. The NST non-stress test is reactive. That means there are two accelerations present. Okay, of 15 beats per minute over a period of 20 minutes lasting for 15 seconds. Okay, now that means that when two accelerations are present, that means NST is fine, non-stress test is fine. Okay, now we have followed by that, what is the plan management in this patient? So you have a patient coming to you just for an antenatal checkup. Okay, so what you will give right now, her blood pressure in the current scenario is 130/90 and NST is fine. So baby is absolutely fine, blood pressure is absolutely normal. Okay, and she's just coming for antenatal checkup. Yes, my dear student, she was a known case of preeclampsia. Yes, she had a more than 140/90 plus proteinuria present, but that was back 26 weeks. Right now it's 33 weeks and she's absolutely fine. So patient is fine, antenatal checkup, BP normal, NST fine. You have to wait till 37 weeks of termination. Very good. Now what is the answer? So we'll wait till 37 weeks of termination. Why you will do? There is no emergency that you will plan an LSCS because she's absolutely fine. NST is reactive. The baby is not having distress. Baby is not having any problem. So you cannot go for LSCS. Give magnesium sulfate. There is no increased blood pressure. There is no preeclampsia. You cannot go for MgSO4. Give dexamethasone and induce. There is no indication for going for inducing the labor. Okay, so the answer goes to wait till 37 weeks of termination. Wait till 37 weeks of termination. Next question. A 28-year-old woman present to the labor and delivery unit at 32 weeks with the regular uterine contractions and lower abdominal pain. She has a history of a previous preterm delivery. Yes, preterm, prior to 37 weeks. On examination, cervix is 3 cm dilated and effaced 80%. Okay. Sir, fetal fibronectin test is positive. That means the patient is in the labor. Anticipating the preterm delivery. So when you are going for the preterm delivery, the first thing you need to keep in mind, are the lungs mature or not? Okay. Now how to check whether the lungs are mature? You go for the fetal lung maturity test and you have to give drugs, 2 drugs, betamethasone and dexamethasone. So the question is asking that what is the dose of dexamethasone? What is the dose of dexamethasone given to mother? Write down the answer in comment section. What is the dose of dexamethasone given to mother? What is the dose of dexamethasone given to mother? Yes, everyone out there who are joined, do answer. What is the dose of dexamethasone? Very good. So we have to give 6 mg 12 hourly 4 doses. We have to give 6 mg 12 hourly 4 doses. Six mg 12 hourly 4 doses. Okay. Now tell me guys. What are the tests that we do? What are the tests that we do for a fetal lung maturity test? What are the tests? First of all, sir, yes, lecithin sphingomyelin ratio. Okay. What else we check in the amniotic fluid in order to confirm that fetal lungs are matured? Yes, LS ratio, it should be more than 2:1. That's correct. What else? Phosphatidylglycerol in amniotic fluid. Very good. What else? Write down in the comment section. Phosphatidylcholine. Okay, but best one is phosphatidylglycerol. Okay, and what are the other tests? We have shake test, we have Nile blue paper test. Okay, so let's write it down. So what are the fetal lung maturity tests? So first of all, we have lecithin, sphingomyelin ratio, that is LS ratio, and it should be more than 2:1. It should be more than 2:1. Okay, then we have phosphatidylglycerol. And amniotic fluid. Okay, and this one is going to be the best one. Okay, this one is going to be the best one. Okay, followed by that we have phosphatidylcholine, in amniotic fluid, or this phosphatidylcholine we can say in maternal serum as well, fetal serum as well. That's why it is not chosen. Okay, then we have Nile blue sulfate test. Or we have shake test. These are all the tests that we do for fetal lung maturity. Okay, now what should be the dose of beta-methasone? So write a formula. You will remember B2D4. Okay, so always remember beta-methacine. Okay, beta-methasone 2 doses, dexa 4. Total it should be 24. So if you give beta-methasone 2 doses, how much you are giving? So you are giving 2 injections. So we are giving 2 injections of 12 mg given 2 injections of 12 mg given 24 hourly intramuscular. That will be a dose of a beta-methasone. And what will be the dose of a dexamethasone? D is 4, so 4 injections. I've told you total kitne mg aana chahiye? 24. So 4 injections, you will give 6, 6, 6 and 6. That is of 6 mg each, D4, 4 doses, and given 12 hourly. Early intramuscular. So this was the question asked, that what is the dose of a dexamethasone? Question was asked, what is the dose of a dexamethasone? Your answer is dose of the dexamethasone is 6 mg 12 hourly 4 doses. And make sure if a patient is a diabetic patient and you are giving these steroids, make sure you only give when the patient is in the hospital, because steroids eventually will increase the blood sugar levels. Steroids eventually will increase the blood sugar levels. Okay, next question. Okay, next topic, that is going to be antepartum hemorrhage. The next topic, that is antepartum hemorrhage. Okay, now what exactly is antepartum hemorrhage? So my dear students, if I define here antepartum hemorrhage, sir, obstetric hemorrhage is of two types. Okay, sir, obstetric hemorrhage, when we talk about obstetric hemorrhage, that means bleeding related to the pregnancy, it's of two types. Okay, so one type is antepartum hemorrhage. So next type, another one is postpartum hemorrhage. Okay, one is antepartum hemorrhage, another one is postpartum hemorrhage. So what is this antepartum hemorrhage? It means when the bleeding is prior to the delivery. Okay, 28 weeks till the delivery. Okay, that is the antepartum hemorrhage. Sir, what is postpartum hemorrhage? Sir, it is delivery till 12 weeks. It is delivery till 12 weeks. Now postpartum hemorrhage we have already studied. Okay, postpartum hemorrhage हमने already पढ़ा हुआ है. Okay, now what exactly is antepartum hemorrhage? Now when we talk about this antepartum hemorrhage, there can be placental causes three. Okay, now what are those antepartum hemorrhage? It means any bleeding from the genital tract, after 28 weeks onwards till the delivery. This is an antepartum hemorrhage. Any bleeding from the genital tract after the delivery till 12 weeks, that is postpartum hemorrhage. Now my dear students, the antepartum hemorrhage, the three main reasons, we have placenta previa, okay, we have vasa previa, we have placenta previa, we have vasa previa, and we have abruptio placenta, Now what do we mean by the placenta previa? So simple words, placenta previa means when the placenta, this is the placenta, when the placenta is implanted in the lower uterine segment. When the placenta is implanted in the lower uterine segment, we call it as a placenta previa. So write it down, placenta implanted in the lower uterine segment. Okay, placenta implanted in the lower uterine segment. Okay, partially or completely. Partially or completely. Okay, so placenta implanted in the lower uterine segment, partially or completely, called as placenta previa. Okay, now depending upon the degree of extension, we have different types. We have type 1, okay, called as lateral. We have type 2, marginal. Okay, we have type 3, partial. We have type 4, called complete. Okay, so we have lateral, marginal, partial, or complete. Okay, now see, placenta is not reaching to the os, lateral, placental edge reaching to the os, marginal, partially covering, type 3, fully covering, type 4. But now this was the old classification. Now the new classification says that there is only low-lying placenta and placenta previa. Okay, there is only two types. Okay, either the low-lying placenta, which is 2 centimeter away from the os, and then these three, marginal, partial, and complete, they are termed as a placenta previa. So new classification says either there is a low-lying placenta 2 centimeter away from the os, or either there is a patient having marginal, partial, or complete, called as placenta previa. Now, if a question will be asked, the presentation. Now, if they ask the question in the form of a presentation of a patient, then how exactly the patient will come? Okay, how exactly the patient will come? So remember, when a patient is coming, patient will complain of painless vaginal bleeding. What will be the patient complaining of? Painless vaginal bleeding. Painless vaginal bleeding. Okay. Along with that, the uterus will be soft. Uterus is soft and non-tender. Uterus is soft and non-tender, and the size of the uterus, and the size of the uterus is corresponding or is equal to the period of gestation. It's corresponding to or equal to the period of gestation. Okay. Now, what exactly are the clinical features? So, patient is complaining of painless vaginal bleeding. So, patient is complaining of painless vaginal bleeding. Along with that, uterus is soft and non-tender. Along with that, uterus is soft and non-tender, and the size of the uterus is corresponding to the period of gestation. Okay. Now, if they ask investigation of choice, it is transvaginal scan. If they ask for the screening, what will be the answer for the screening? Okay, it's trans-abdominal scan. It's trans-abdominal scan. Okay. Now, the question was asked in your exam that around 24 weeks, okay, the case of placenta, low-lying placenta was seen. What is your next step? So if a question is mentioning that around 20 weeks, around 25 weeks, 28 weeks, it was seen that there is a low-lying placenta, what is the next step? So we are gonna do the USG again. We are gonna do the scan again at 32 weeks, because we can expect that from the lower segment the placenta can go for in the upper segment. This is called as placental migration. इसको क्या बोलते हैं? Placental migration. So if question mentions at 28 weeks or 25 weeks USG was done and this placenta was in the lower uterine segment, what is the next step? The next step is, what is the next step, bache? The next step is do the USG again and check that whether it is going into the upper segment, and this going from lower segment to upper segment, it's called as a placental migration. Now, after you diagnose the placenta previa, now it's a confirmed case of placenta previa. Okay. Now there are two things. Okay. So what are the two things after diagnosing it? The two scenarios that can be there. If it is less than 37 weeks, if it is less than 37 weeks, so I am going for expectant management. I am going for expectant management. Okay. Less than 37 weeks, I'm going for expectant management. Okay. Now, if more than or equal to 37 weeks, now patient of placenta previa is coming to me at 37 weeks or more than 37 weeks, there is only one management. I am going for cesarean section. Okay. So remember, once you diagnose the placenta previa, if it is less than 37 weeks, I'm going with an expectant management. Okay. And if it is more than 37 weeks, I'm going with the cesarean section. Now, sir, what exactly is an expectant management? Expectant management, you should only go. Expectant management means you should only go when there is no risk. Continue pregnancy with no risk. Continue pregnancy with no risk. Okay. Now, when to choose this expectant management? First of all, there should be no active bleeding, the baby should not be in distress, and there should be no unstable vitals. So first of all, so no active bleeding, there should be no fetal distress. Okay. One more thing, so patient should be hemodynamically stable. Patient is hemodynamically stable. Okay, that is expectant management. That is expectant management. Now if a patient is in distress, there is active bleeding, vitals are not stable, even if it is less than 37 weeks, still you have to mark what? Cesarean section. So only mark expectant management when there is no active bleeding, no fetal distress, and there should be no risk to the pregnancy. Okay, now this expectant management, we follow one regime. This expectant management, we follow one regime, and the regime is called as McAfee-Johnson regime. What is the name of the regime, my dear students? So the regime is called as McAfee-Johnson regime. Okay, the regime is called as McAfee-Johnson regime. Now what exactly is McAfee-Johnson regime? It says admit the patient, the McAfee-Johnson regime, admit the patient, okay, followed by that arrange the blood, followed by that arrange the blood, okay. If Rh negative, anti-D. If Rh negative, give anti-D and give steroids for fetal lung maturity. Give steroids for fetal lung maturity. Okay, and what are the steroids? You already know: beta-methasone, dexamethasone, beta-2 dexa 4. Okay, so this is all about the placenta previa. So painless vaginal bleeding with a soft uterus, the period of gestation, the height of the uterus is corresponding to period of gestation. Okay, and the case is placenta previa. Okay, and if 37 weeks, cesarean section, less than that, hemodynamically stable, no distress, no bleeding, you go with the McAfee-Johnson regime. Okay, now let's answer this question. A 32-year-old pregnant woman at 32 weeks, at how many weeks? At 32 weeks of gestation, she present with a painless vaginal bleeding. She is denying any abdominal pain or uterine contractions. Vitals are stable. Ultrasound confirmed that this is a case of a low-lying placenta which is partially covering the internal os. What should be the most appropriate next step in the management? Now, at 32 weeks, the placenta previa case is there with the vitals stable. With vitals stable, okay? What should be your next step? Write down in the comment section answer, everyone. So, what should be the next step of this particular condition? What should be the next step of this particular condition? Okay, what should be the next step of this particular condition? Yes, write down everyone the answer. Yes, very good. Sir, we admit the patient. Okay, we admit the patient and we admit the patient for observation and initiate corticosteroid therapy. We admit the patient for observation and initiate the corticosteroid therapy Is that clear? Is that clear to everyone? Is that clear to everyone? Yes? Chalo. So vitals are stable, you go with an expectant management, we'll admit and we initiate the steroid therapy. Now next one is abruptio placenta. Now what exactly is abruptio placenta? Yes sir, it means the premature separation of normally implanted placenta. It means the premature separation of the normally implanted placenta. Now what can be the reasons of these risk factors for this premature separation of the normally implanted placenta? Sir, the reason can be, first thing, reason can be, pehla reason, sir, increased blood pressure. Sir, it can be second reason due to the trauma. It can be due to the multiparous woman. Okay, or it can be the triplets. Now write it down. First of all, sir, What is abruptio placenta? That placenta is separated abruptly, all of a sudden. Okay, it is premature separation of premature separation of normally implanted placenta. There is a premature separation of normally implanted placenta. What are the risk factors? I've already told you that mainly risk factors like hypertension, okay, followed by that we have trauma, followed by that multiparous woman, or a patient with a previous abruption. Or a patient with a previous abruption. Okay, now types of abruptio placenta. Now we have three types: either we have concealed, we have revealed, or we have a mixed type. So what are the three types? We have concealed, we have revealed, or we have mixed. We have mixed. Now what exactly is the difference between concealed and revealed? What exactly is the difference between concealed and revealed? When we talk about a concealed abruption, my dear students, you can see that this blood is not escaping out. This blood remains intact over here. Okay, but in case of revealed one, this blood is escaping out. Okay, now if patient is not bleeding, okay, but all the symptoms, all the presentation is having of a abruption, then the type of abruption is called as concealed abruption. Now sir, when this blood is remaining here only, it is not escaping out, what happens? This blood is going into the uterine musculature. Okay, now this blood is going to the uterine musculature. There is an extravasation of blood. There is a extravasation of blood into the uterine musculature. There is an extravasation of the blood into the uterine musculature. This is classically called as a type of the uterus that you've seen in an abruptio placenta, called as covalare uterus. क्या बोलेंगे इस uterus को बच्चे? So we call it as covalare uterus, or we call this uterus as bruised uterus. Okay, we call this uterus as bruised uterus. So simply remember C for covalare and C for concealed. So this concealed type of abruption, this concealed type of abruption is having a type of a uterus called as covalare uterus or bruised uterus. It is having covalare uterus or bruised uterus. Clear? Okay, in revealed, what is happening? Bleeding is escaping out. Bleeding is escaping out. They can ask the image, this particular image, or they can ask which of the following condition will have this type of uterus. So you make sure you remember that it is classically seen. Make sure that this is classically seen in which type of abruption? It is seen in concealed type of abruption. Okay, it is seen in concealed type of abruption. What exactly is there? It's extravasation of blood into uterine musculature. It's an extravasation of blood into uterine musculature. Okay, this is called as bruised uterus or covalare uterus. Okay, now what will be the presentation of a patient having an abruptio placenta? It will be exactly opposite to the placenta previa. So in placenta previa, the presentation of a patient was having a painless vaginal bleeding. There was what? Painless vaginal bleeding. But here patient will have a painful vaginal bleeding. Patient will have painful vaginal bleeding. Okay, in which trimester? Usually third trimester. Okay, in which trimester? Third trimester. Okay, now on per abdominal examination, the patient will have, in case of placenta previa, there was soft non-tender uterus. Here the uterus is tender. And raised. Okay, followed by that fetal heart sound, not heard. Followed by that fetal parts or not palpable. And followed by that the height of the uterus, it was same in the placenta previa. Here the height of the uterus, due to the hypertension, due to the trauma, due to the extravasation of blood into this musculature, it will be more than the period of gestation. It will be more than the period of gestation. Now bache, if a presentation of a patient will be same like a abruptio placenta and they will mention fetal parts are palpable, like a patient is having a painful vaginal bleeding with a tender uterus, fetal parts are palpable, your diagnosis goes to uterine rupture. Your diagnosis goes to uterine rupture. So make sure if it is mentioned that fetal parts are palpable, make sure the diagnosis is uterine rupture. If it is not palpable, okay, then the answer goes to the abruptio placenta. The answer goes to abruptio placenta. Clear? The answer goes to abruptio placenta. Okay, now we have a classification of abruptio placenta called as Page classification. It simply says that mild, moderate and severe. Grade 0 of Page classification says that a patient having this is asymptomatic. Patient is asymptomatic. Okay, when we talk about grade 1, 2 and 3, it is mild, it's moderate and severe. Mild, moderate and severe. Okay, mild, moderate and severe. Now in case of mild abruptio placenta, okay, patient will have pain plus bleeding. Patient will have pain plus bleeding and the fetal heart sound will be normal. Fetal heart sound kya hoga? Normal. When we discuss about grade 2, which is moderate type, there will be pain plus bleeding, but along with that fetal distress is seen. Fetal distress will be present. Okay, in severe type of abruptio placenta, there will be fetal death, plus there will be maternal shock. There will be fetal death plus maternal shock or coagulopathy, DIC. That is a Page classification. Grade 0, 1, 2 and 3. Grade 0, 1, 2 and 3. Mild, moderate, severe 1, 2, 3. 0 is asymptomatic. Okay, the more important question that they can ask from abruptio placenta is the management. Okay, now a patient of abruptio placenta, now placenta previa, you already know, sir, if more than 37 weeks I'm going with a cesarean section, or 37 weeks cesarean section. So if it was less than 37 weeks, I was going with an expectant management, but I only go with an expectant management when the vitals are stable, there is no active bleeding, patient is hemodynamically stable, there is no fetal distress. Okay, there should be not any risk, then only I choose for McAfee-Johnson regime. But if in case it's not following this, there is any risk to the pregnancy, again less than 37 weeks, the answer should be cesarean section. Now in case of an abruptio placenta at term, okay, at term, now two scenarios. Now sir, at term, if vitals stable, all right, first if a fetal distress is there, any condition like this, fetal distress is present, you cannot go for expectant management, you know the answer is going to be cesarean section. You know the answer goes to cesarean section. Okay, and if there is no emergency, that means the vitals are stable, that means mother is not at risk. If no emergency is there, if vitals are stable, okay, fetal distress is not there, and then the answer goes to, so you will have to go for induction of labor, will induce the labor prior to the onset of the contractions. Okay, that is induction of labor. And when this labor needs enhancement, okay, that is called as augmentation of labor. Here there was no labor present in abruptio placenta. I am inducing the labor with the help of an artificial rupture of membranes. Okay, and when the artificial rupture of membranes will be there, they will release the endogenous prostaglandins. When the endogenous prostaglandins will be released, they will induce the labor, so we can go for normal vaginal delivery. So make sure you remember that in case of an abruptio placenta, you are going for induction of labor. Okay, followed by that we induce the labor with the help of artificial rupture of membranes. Artificial rupture of membranes will release prostaglandins, and prostaglandins will help in inducing the labor. We go for normal vaginal delivery. So make sure when you answer in case of an abruptio placenta, answer that we are going for induction of labor with artificial rupture of membranes, normal vaginal delivery. Clear? Clear? Now around 32 to 34 weeks. Around 32 to 34 weeks. Okay. First of all, what you will do? Sir, resuscitation always. Yes, you know. Any case of bleeding, first of all, guys, resuscitation. Okay. Then you will give steroids. You'll give steroids to mother for fetal lung maturity. Okay, and then if no emergency, again, if no emergency less than 34 weeks, okay, do one thing, continue the pregnancy. Continue the pregnancy. Okay, if more than 34 weeks, if more than 34 weeks, go for NVD. Go for NVD with artificial rupture of membranes. Go for NVD with artificial rupture of membranes. With artificial rupture of membranes. Okay, so that is all about the abruptio placenta. That is all about the abruptio placenta. That's all about the abruptio placenta. Clear? Chalo. Next is the question that I have asked. A 28-year-old woman at 34 weeks of gestation. A 28-year-old woman at 34 weeks of gestation present with a painless vaginal bleeding and the fetal bradycardia. Okay, on ultrasound there is a velamentous cord insertion with the fetal vessels crossing the internal cervical os. What is the most likely diagnosis? So a female is there at 34 weeks of gestation. Okay, bacha, at 34 weeks of gestation, sir, she's having a painless vaginal bleeding. Okay, she's having a painless vaginal bleeding and a fetal bradycardia. There is a velamentous cord insertion over there. Okay, the fetal vessels are crossing the internal cervical os. What is your diagnosis? So V for velamentous cord insertion, V for vasa previa. We have discussed in the main sessions. Then whenever there is a velamentous cord present at os, or there is a splitting of the velamentous type of placenta, splitting of this cord occurring at the os with the painless vaginal bleeding, the diagnosis is going to be vasa previa. The diagnosis is going to be vasa previa. Okay, now let's understand what exactly is vasa previa. Now let's understand what exactly is vasa previa. Now if we define the vasa previa, sir, it means when there is a velamentous cord, we have a velamentous cord present at os. We have a velamentous cord present at os, or the splitting of the cord, or there is a splitting of cord at os. This is called vasa previa. This is called vasa previa. Okay, what is the presentation of a patient of a vasa previa? Okay, first of all, again, it is a painless vaginal bleeding. there is a painless vaginal bleeding. Along with that, there is no tenderness, but due to this bleeding, or due to this fetal cause of bleeding, due to the bleeding coming from there can be a fetal distress scene, because the compression of cords is also there, because this cord is present at the os. Okay, so this is a presentation of a patient having a vasa previa, painless vaginal bleeding, fetal distress, but there is no tenderness. There is no tenderness. Okay, now if you look at the picture, this is vasa previa type 1. We can say we have two types, type 1 and type 2. So what is the difference between type 1 and type 2? First thing, in type 1 we have just a filamentous cord insertion. Now if you see, this is the placenta over here. Okay, these are the vessels, and then we have a cord over here. Okay, now these vessels are present at internal os. When the filamentous cord is present at internal os, or the splitting of the cord is occurring at this point, my dear student, this is a case of vasa previa. This is a case of a vasa previa. Number one thing. Number second is, if we have a bilobed placenta. If we have a which type of placenta? We have a bilobed placenta. This is a one lobe, this is another lobe. Okay, now we have a bilobed one, two equal lobes. But when we have a one big lobe and one small lobe, and you can see the cord here again is present at the os. Okay, so due to this head compression on the vessels, that's why the baby is having fetal distress. Okay, and can we go for the normal vaginal delivery in these conditions? No sir, because it can cause a rupture of these vessels, which can cause more fetal distress, more bleeding. So only management for vasa previa is gonna be the cesarean section. First thing. Second thing is the two lobes, one big and one small lobe. Such type of placenta we have discussed in our main sessions are called as succionate placenta. Succionate placenta. Okay, so these are unprotected blood vessels, and if we are trying to go for the normal vaginal delivery in such conditions, they can cause the more bleeding or the rupture of vessels. So how you will confirm the diagnosis? We can go for transvaginal scan with color Doppler. Okay, with color Doppler. With Doppler is important to check the blood circulation. Along with that, we have to go for apt test. Okay, we have to go for apt test. Sir, what exactly is this apt test? This is an alkaline denaturation test, also called as Singer's alkali test, and this test will help me to differentiate between the maternal and fetal blood. This test will help me to differentiate between the maternal and the fetal blood. Now, the fetal RBCs, they are resistant to the alkaline denaturation. Okay, fetal RBCs are resistant to the alkaline denaturation. So, the blood will be colorful. If it is colorless, that's going to be the maternal side origin. If it is colorful, that's going to be the fetal origin. So, write it down. So, this apt test or alkaline denaturation test will tell me about, or it will distinguish the blood of, or it will distinguish the origin of the blood, whether it's from the maternal side or the fetal side. Okay, so you can mention the test helps us to between maternal and fetal blood. If it is colorless, it's going to be maternal. If it stays red, it's going to be fetal blood. And the management for this condition is only one management, cesarean section, because you cannot go for a normal vaginal delivery. So that was all about the antepartum hemorrhage. That's placenta previa, abruptio placenta, and vasa previa. Okay, recall placenta previa management focus more by बच्चों management. If a patient is confirmed case of a placenta previa at 37 weeks, you go with a cesarean section. Less than that, you go with an expectant management, depending upon whether the vitals are stable, whether there is an active bleeding, or the baby is in the distress. If any of this is that, you go again with a cesarean section. Followed by that, abruptio placenta at term. If distress, cesarean section. If not distress, you go with a normal vaginal delivery with artificial rupture of membranes. You induce the labor with ARM. ARM will release the endogenous prostaglandins and they will induce the labor. You go with a normal vaginal delivery. Is that clear? Is that clear? Yes, sir. Okay, next one we discuss about vasa previa, filamentous cord present at os, okay, or the splitting of the cord present at os. And if a patient is having a vasa previa, you directly go with the cesarean section. Clear? Yes. So let's have a small 10 minutes of break. Okay, then we continue with the remaining part. Okay, then we'll continue with oligohydramnios. Okay. Let's start, guys. I'm audible and visible. Please update me in the comment section. We'll start with the remaining chapters. Yes, everyone out there, can we start? So we are cleared with the multiple topics so far: endometriosis, we discussed GDM, okay, we discussed antepartum hemorrhage, we discussed eclampsia, we discussed the fetal lung maturity test and the drugs, okay. Now we'll start with the amniotic fluid dynamics. We'll start with the oligohydramnios and polyhydramnios. Followed by that, we'll go with the prolapse, then the molar pregnancy, then the infections, and so on. Okay. So let's start. Next question. A 34-year-old pregnant woman present for a routine prenatal visit at 36 weeks. On examination, the fundal height measure was the small for gestation. That means it's less than, height of the uterus is less than the period of gestation, okay. An ultrasound is performed and which revealed that the amniotic fluid is reduced. So there is a reduced amniotic fluid with an AFI of 5 centimeters, with an AFI, amniotic fluid index, of 5 centimeter. On examination, uterine height reveals at 16-week size, very less. Which of the following is the cause for the above given clinical case? Okay. Now the question over there is that this is a case of an oligohydramnios. As you know that there is a reduced amniotic fluid. You know what is the diagnosis? So the diagnosis is oligohydramnios. So the diagnosis is going to be oligohydramnios. Okay. So if we discuss about this oligohydramnios, okay. Now tell me, my dear students, what can be the possible causes? So let's discuss what exactly is oligohydramnios. It means when the amniotic fluid is less than 500 ml or the AFI is less than 5 centimeters, okay, or the AFI is less than 5 centimeters. Now what can be the possible causes for this oligohydramnios? We have discussed some causes, okay. We discussed about the preeclampsia, that there is a decreased blood flow to the kidneys which will lead to the decreased GFR, which will further decrease the urine formation, and eventually the mother is going to have an oligohydramnios. But the most common cause, okay, the most common one is bilateral renal agenesis, and you just write the causes bilateral renal agent, because if we talk about the most common cause of poly and oligohydramnios, it's idiopathic. But most common cause for severe oligohydramnios, if they ask, then the answer goes to bilateral renal agenesis. Agenesis, okay. Then next one is going to be post-term pregnancy. Next one is going to be post-term pregnancy. Then patient taking NSAIDs or ACE inhibitors, because any ACE inhibitors have side effects, okay. They decrease the urine formation, okay, and eventually baby will have oligohydramnios. Or a case of amniocentesis, or the case of amniocentesis, or the case of leaking, or the case of leaking, okay. These are all the causes. These are all the causes for oligohydramnios. These are all the causes of oligohydramnios. Now we have a Potter's triad that we see in a patient of an patient having oligohydramnios, okay. What is this Potter's triad? We'll see that there is pulmonary hypoplasia, three things: pulmonary hypoplasia, okay, first one. Second one, there will be contracted limbs due to this decreased amniotic fluid, contracted limbs, and there will be renal anomalies. There will be renal anomalies. So what is Potter's triad? So pulmonary hypoplasia, contracted limbs, and the renal anomalies, okay. Now if you look at this image, you can see there's a Potter facies with the low set ears, the beaked nose, there are prominent epicanthic folds and downward slant to the eyes here. Okay, and followed by that you will see the limb deformities that we mentioned in the triad. Okay, and there will be a respiratory failure due to the pulmonary hypoplasia. Okay, and bilateral renal agenesis will cause the reduced fetal urine excretion. When the fetal urine will be less, baby will have oligohydramnios, due to which there is a fetal compression. There is a fetal compression. Is that clear? So this is all about oligohydramnios. Now what will be the treatment for this management? First of all, you have to increase the fetal surveillance. You have to increase the fetal surveillance, and we can go for amnio infusion as well. We can go for amnio infusion as well. Okay, now the question was asked that which of the following can be the cause for an oligohydramnios. Okay, which of the following will be the cause of oligohydramnios? We discuss. Sir, cleft palate, no. Gastrocrisis, no. GDM, no. These three are all the causes for what? These three are all the causes of polyhydramnios. Okay, now the question is oligohydramnios. The answer is going to be bilateral renal agenesis. Answer is going to be bilateral renal agenesis. When the kidney is not working well, okay, there is no fetal urine excretion, there is oligohydramnios. Very simple. Now next question. A 26-year-old primary gravida at 30 weeks of gestation, she came for a regular antenatal checkup. On examination, you saw that the height of the uterus was more than the period of gestation. The height of the uterus around 34 weeks, but the period of gestation was 30 weeks. That means large. Okay, the TVS revealed now she has an amniotic fluid index of 26. Now which of the following condition is most likely to be associated? Now this is a diagnosis of, what will be the diagnosis? This is a diagnosis of polyhydramnios. This is a diagnosis of a polyhydramnios. This is a diagnosis of a polyhydramnios. Now let's understand first the causes and then go back to the question. Now what is polyhydramnios? So polyhydramnios is when the AFI, amniotic fluid index, is more than 25 centimeter, or the amniotic fluid AFI is more than 25 centimeter, or the amniotic fluid is more than 2000 ml, or the amniotic fluid is more than 2000 ml. Okay, now what can be the possible causes? Now what can be the possible causes? First of all, diabetes. First of all, the cause will be diabetes. Okay, followed by that we can have cleft lip, or palate. We can have a cleft lip or cleft palate. Okay, and this cleft lip and cleft palate or congenital GI anomalies, they are the most common cause of a severe polyhydramnios. And in case of an oligohydramnios, I've mentioned that the most common cause of a severe oligohydramnios, your answer goes to renal anomalies or bilateral renal agenesis. Okay, what can be the other causes? If a twin pregnancy is there, more amniotic fluid. Okay, so twin pregnancy. We also, GDM we wrote, there can be esophageal or duodenal atresia. There can be esophageal or duodenal atresia. These can be all the causes of a polyhydramnios. These can be all the causes of a polyhydramnios. When there is a big uterus, okay, over distension of the uterus, okay, the mother can have a dyspnea, okay, or respiratory distress. Or respiratory distress. Okay, now if we talk about the treatment, what can be the treatment? We can give an NSAID, a drug, endomethacin, okay, 25 mg, and this endomethacin drug will help to decrease the urine output, And when the urine output is decreased, eventually what will happen? Patient will have a normal amniotic fluid levels. Or we can also go for a therapeutic amniocentesis. Or we can also go for therapeutic amniocentesis. We can also go for therapeutic amniocentesis. क्या करेंगे? We'll take this amniotic fluid. One is diagnostic. Diagnostic we use for fetal lung maturity. We check the neural tube defects. So that is diagnostic amniocentesis. Here you are using amniocentesis as a treatment, so it is therapeutic amniocentesis. Okay. Now the simple question was asked. Okay. Make sure that this endomethacin you will not use. Don't use beyond 32 weeks. Okay, why? Because it can cause patent ductus arteriosus. Okay, it can cause patent ductus arteriosus. I've already mentioned this in teratogens. Okay, now the question was, which of the following is most likely associated? Now my dear students, just now we discussed that the most likely association of polyhydramnios will be cleft palate, post urethral valve, NSAIDs. These all three are the causes of oligohydramnios. ये तीनों किसके causes है? Oligohydramnios. Okay, now we have a different color of amniotic fluid as well. When the red color of amniotic fluid, you will see in case of an antepartum hemorrhage, usually the abruption. We can see the green color amniotic fluid in the meconium aspiration, meconium stained. If we see the tobacco juice color, it's an intrauterine death. You will see golden color in RH isoimmunization. Okay, these are all the different color of an amniotic fluid. Okay, straw color is a normal amniotic fluid. Now, depending upon whether to go for an external cephalic version or not with respect to the amniotic fluid levels. Now this amniotic fluid level, it's maximum at 32 to 34 weeks. It's maximum at 32 to 34 weeks. Now, if a patient is having a transverse lie or a shoulder presentation and a female is not in a labor, now at that time, should we go for a cesarean section? No sir. At that time, we'll try to rotate the baby externally. Okay, but you will only rotate this baby externally when the amniotic fluid levels are decreased. And usually what time the amniotic fluid levels are decreased? After 36 onwards, the amniotic level keeps decreasing, because at 32 to 34 weeks it's 1000 ml. So around 36 weeks it's 800, then followed by that 40 weeks is 600. Now at 36 weeks the AFI is less than compared to 32 to 34 weeks. So if at 36 weeks a patient is coming with a transverse lie, not in labor, mark cesarean section, number one thing. If not in labor, so we can go for external cephalic version. Okay, sir, what if we do external cephalic version at 32 weeks only? The amniotic fluid levels is so high, it is increased, the baby will keep changing its position. So it's only advised to do after 36 weeks onward, so that even if we go for external cephalic version, the baby will not change its position. So around 36 weeks, the amniotic fluid levels are less than compared to 32 to 34 weeks, so that we can go for external cephalic version. We can go for external cephalic version. Is that clear? Is that clear? Next is gonna be next question now. Okay, so it's all about oligohydramnios or polyhydramnios. It's all about oligohydramnios and polyhydramnios. Clear? Clear everyone? Yes? Chale. Now next one. Okay. At a 62-year-old postmenopausal woman present with complaints of pelvic pressure, incomplete voiding and the sensation of something coming out. Now she's having a pelvic pressure, okay, and she feels something is coming out, and on the examination she feels something is coming out of vagina. On examination you reveal that she is a case of uterine prolapse with the decubitus ulceration over the exposed cervix. Now there, on the dependent part of the cervix, there is an ulcer called as decubitus ulcer, which is seen in a prolapse. Which of the following is the best definitive management? Which of the following is the best definitive management in this case? So a 62-year-old woman, okay, postmenopausal, okay, followed by that she's feeling something is coming out. Along with that, other features which will help in the diagnosis of uterine prolapse. Patient can feel a pain, okay, due to the stretching of these ligaments, and patient will also feel the back pain as well, and ulceration over the dependent part of the cervix called as decubitus ulcer. Okay, it's a non-healing ulcer. Which of the following is the best definitive management in this case? Now, when we talk about the prolapse, guys, first of all, in the uterus, we have a support of the uterus, we have cardinal ligament, we have transverse ligament, we have McEnroe's ligament, uterosacral ligament. These are all support of the uterus. Okay, along with that, if we talk about the pelvic floor of the uterus, we have a muscle levator and we have a levator and muscle over there. Okay, now my dear students, when the support of the uterus is going decreased, it's going weak. Okay, the support of the uterus is weak, this uterus is descending down, down, down. Now I've clearly discussed in the part 1 that in case of an inversion there is only upside down, but यहाँ पे क्या होता है, there is descending of uterus, it's coming step by step down, and this is a case of a prolapse. With respect to that, at which level it is going on, we have a classification called as Shaw's classification. That's what we are going to discuss. But here the question has been asked from the management point. Now management depending upon the age and the condition of the patient. Now we have 2-3 scenarios. Either the patient will be young, either patient will be middle aged, completed family or not completed family, either patient will be elderly, okay, or either patient will be elderly but not fit for surgery. So these 3-4 scenarios will learn and what will be the management of each of the following. Okay, now my dear students, here let's discuss first the topic and then go back to the question. Okay, yes, you guys are right in the answer. Now classification of the prolapse. Now my dear students, in the anterior part of the uterus there is a bladder. So when it is descending down this uterus, it is involving the bladder as well. So patient will have a cystourethrocoele on the anterior vaginal wall. Okay, then the posterior vaginal wall, rectum. So patient will have a enterocoele and rectocoele. Patient will have enterocoele and rectocoele. So while we lift the uterus up from the anterior side, we'll go for anterior colporrhaphy. From posterior side, we'll do a posterior colpoperineorrhaphy, and together it is called as pelvic floor repair or Ward and Mayo operation. Is that clear? So cystocoele features, enterocoele and rectocoele, all these features, if we have to treat for anterior vaginal wall, we'll do anterior colporrhaphy, and for posterior vaginal wall, we'll do posterior colpoperineorrhaphy, and together anterior colporrhaphy and posterior one, we call them as pelvic floor repair. We call pelvic floor repair, or we call it as Ward and Mayo operation. Is that clear? Now followed by that, depending upon the degree of a prolapse, if this uterus is coming down into the vagina, okay, if this cervix is descending down into the vagina, this is called as a first degree. Okay, descent of the cervix in the vagina. If the descent of the cervix into the introitus, this is the level of introitus, and if the cervix is at the level of introitus, you call it as a second degree. Okay, if there is a descent of the cervix outside the introitus, now the cervix is outside the introitus, you call it as third degree prolapse. Okay, and if all the uterus is out, you call it as procedentia. So normal uterus. Okay, and then with respect to the level of introitus, if the cervix is in the vagina, we call it as first degree. If at the level of introitus, we call it as a second degree. If outside the introitus, we call it as third degree. If whole uterus is coming, we call it as procedentia. Now students, simple question was asked. A 58-year-old multi-parous lady, she is presenting to the gynecology clinic with the complaints of the mass descending per vagina. Now she is feeling something is coming out in the vagina. On examination, you note that the external os lies at the level of introitus. Now cervical os, cervix is at the level of introitus. As per the classification, it is a which degree of uterine prolapse? Write down in the comment section. It is the which degree of uterine prolapse? Okay, which degree of uterine prolapse? Which degree of uterine prolapse? Tell me, which degree of uterine prolapse? Which degree of uterine prolapse? So this is going to be second degree. This is going to be second degree. Is that clear? Is that clear? This is going to be second degree because it is at the level of introitus. One question from the point of view that degree of prolapse, you have to see whether the cervix into the vagina, whether at the level of introitus, whether outside the introitus, whether whole cervix is outside. First, second, third, and procedentia. Now, next question that they can ask is from the management of a prolapse. Second question that they can ask is from the management of the prolapse. Sir, what can be the reason for this prolapse? Mismanaged third stage of labor, increased abdominal pressure, some connective tissue disorders. Okay, these can all be the reasons for what? These all will be the reasons for the prolapse. Multiparous woman. Okay, multiparous woman. Also, postmenopausal woman, that is given in the question, have decreased estrogen levels. Okay, have decreased estrogen levels. That can all that can also cause a uterine prolapse. Okay, now four conditions. Now, if a lady is there having a uterocervical prolapse in a reproductive age, who needs a future childbearing, she wants to conceive in the future, or she's a very young woman, okay, sometimes primigravida, or sometimes she haven't not conceived at all, and a patient is having a prolapse. So can we take a uterus out? No sir, we'll go for sling surgery. क्या करेंगे तब? So we'll go for sling surgery. We'll go for sling surgery, and the best one is going to be, you write, best one is going to be Shirodkar. Best one is going to be Shirodkar sling surgery. Best one, it's going to be Shirodkar sling surgery. Okay, next one is going to be a prolapse in a reproductive age female who do not need a future childbearing. Now, the lady who do not need a future child, okay, the family is complete. We go for a surgery called as Fothergill surgery. We go for a surgery called as Fothergill surgery. This is the NEET PGPYQ Fothergill surgery. So this surgery is also called as Manchester repair. This surgery is also called as Manchester repair. Number first thing, this surgery is also called as Manchester repair. Okay, now the includes two steps. Okay, it includes two steps. First, there is cervical amputation. First, there is cervical amputation, and second, there is plication of cardinal ligament. There is plication of cardinal ligament. Okay, so next one is the lady who does not need a future child, So what will be the treatment? In a lady? So we can go for a Fothergill surgery or the Manchester repair, and make sure in a question it will be mentioned that if a cervical amputation was done, what is the name of a surgery? You will write Fothergill surgery. Okay, even DNC might be needed in that case. Okay, when we are going for Manchester repair. Okay, due to the reason we are going for cervical amputation, because cervix के ऊपर बढ़ रहा है and it's coming out, so we'll cut the part of the cervix. Now, if a lady is having a prolapse, she's postmenopausal female who has completed the childbearing, she does not have any complication, sir, you will go with vaginal hysterectomy, or we'll go with vaginal hysterectomy with pelvic floor repair. What is this pelvic floor repair? Anterior colporrhaphy plus posterior colpoperineorrhaphy. Anterior colporrhaphy for anterior vaginal wall, for cystocele and urethrocoele, and for posterior one, okay, rectocele. Is that clear? Okay, so anterior colporrhaphy plus posterior colpoperineorrhaphy. Together it is called as Ward-Mayo hysterectomy. It is also called as Ward-Mayo hysterectomy. Okay, it's also called as Ward-Mayo hysterectomy. Is that clear? Or pelvic floor repair. Now next one is gonna be prolapse in a female. Now if a female is having a prolapse, 65-year-old, and she's having some complications, okay, or she's having some contraindications for the surgery, like increased blood pressure, okay, like diabetes, that means her pre-anesthetic checkup, she's not fit for the surgery, okay, she's not fit for the surgery. For them we go for Lefort's colpoclasis. Lefort's colpoclasis. Okay, now in this condition that we discuss, that if a female is having, now in this condition, if a female is 62-year-old post-menopausal, okay, and she's having a case of a prolapse, she does not have any contraindication for surgery. In elderly people, post-menopausal, childbearing is complete, you go for vaginal hysterectomy. We go for vaginal hysterectomy with pelvic floor repair. So what is this pelvic floor repair? This is anterior colporrhaphy plus posterior colpoperineorrhaphy. Is that clear? Anterior colporrhaphy for anterior vaginal wall, posterior colpoperineorrhaphy for posterior vaginal wall. Is that clear? So this was all about uterine prolapse. This was all about uterine prolapse. Most important ligament support, that is McEnroth's ligament. Okay, overall best support of the uterus, that is levator ani muscle. Question will be asked, which of the following is not a ligament support of the uterus? Broad ligament. Is that clear? Yes, we also give this exercise prior to this prolapse, okay, so that it will prevent the prolapse. Default colpoclasis, I've already discussed that it is for the people who are contraindicated for surgery. Ring pessary, yes, we use in the beginning because the patient will not be urinate or defecate while having a prolapse, so we use a ring pessary so that it will have a temporary relief. But on the long term, this is not the treatment. Okay, disadvantages, you cannot use it for long term, but for the short term, to defecate and urinate, we usually use ring pessary initially. Is that clear? Okay, now let's move to the next question. Let's move to the next question. A 19-year-old girl comes with 3 months of amenorrhea with excessive vomiting, blood pressure 110/70, and on per abdominal examination the fundal height is 18 weeks. Doctor said do the USG. Okay, doctor advised the USG, and on USG the report showed this. Okay, what is the appearance? So this is classical snowstorm appearance. क्या बोलेंगे बच्चे इसको? Sir, it is snowstorm appearance. Or this appearance is same like a cluster of grapes. Okay, या तो cluster of grapes. Snowstorm appearance or cluster of grapes appearance. What will be the management? What will be the management? So a female having amenorrhea, excessive vomiting, blood pressure 110/70. Okay, USG is given below. This is a diagnosis of, what is the diagnosis, bache? So the diagnosis of molar pregnancy is there. Hydatiform mole, vesicular mole is there. Okay, now what will be the management? So now let's discuss what is complete mole. Okay, now in complete mole there is a abnormal fertilization. Okay, molar pregnancy में क्या होता है? Abnormal proliferation of a fertilization. Okay, whatever that zygote is there, whatever embryo that is there, now due to the abnormal proliferation, okay, वहाँ पे small cyst बन जाती है. Okay, and if it is not treated, it can lead to the cancer as well. Okay, it can lead to the cancer as well. Okay, so what is this? It's an abnormal proliferation. Okay, abnormal proliferation. Chalo. Now, sir, if we talk about a complete mole, first of all, the presentation of a patient having this complete mole, patient will complain of a painful vaginal bleeding, or patient will complain of bleeding per vaginal. Okay, patient will complain of bleeding per vaginal. Okay, followed by that due to the increased levels of beta hCG. Now you already know that this beta hCG is responsible for the vomiting. That's why the patient here is complaining of excessive vomiting. Now remember, there is hyperemesis. There is hyperemesis, and which will lead to what? Metabolic alkalosis, which will lead to metabolic alkalosis. Okay, always remember, vomiting में metabolic alkalosis होता है, hypokalemia, diarrhea में metabolic acidosis. Okay, followed by that there will be thyrotoxicosis, because the subunits of beta hCG and TSH are same, so that यहाँ पे क्या होता है, thyrotoxicosis भी होता है. Okay, that's what you call thyroid storm. इसको आप क्या बोलते हैं? Thyroid storm. Okay, also the levels of beta hCG are increased, and patient also have a complaining of respiratory distress. Increase beta hCG. This is a complete mole. Okay, presentation of a patient. Now, if we talk about the management of this complete mole, the management is suction and evacuation. What is the management, bache? So management is suction and evacuation. Now the suction and evacuation, followed by that will go for slow curettage. Because we have to take these abnormal, whatever the proliferation, abnormal proliferation of the cells is over there, we need to take it out, because I've already discussed that agar ye wahi rahega, if it in case it remains inside only, they will cause a gestational trophoblastic neoplasia. Okay, and gestational trophoblastic neoplasia mein kya aayega? There will be invasive mole, there can be choriocarcinoma, there can be a placental site trophoblastic tumor. So that's why all this abnormal proliferation of these cells we have to take out. So we also go for curettage. Okay, followed by that we have to do the USG. Okay, sir, why we are going for ultrasound? In order to rule out all the tissues which were there, the abnormal tissues, abnormal cells over there are out or not. So to USG to check retained bits, okay. Followed by that you have to do chest x-ray, because this can metastasize to lungs. If invasive, it can metastasize to lungs, giving a classical appearance in the lungs. What is this appearance called as? This has been the question asked as well. It is called as cannonball metastasis. And as per the FIGO classification, which stage the metastasis to lungs is there? It is stage 3. Okay, now do chest x-ray. Why we are doing chest x-ray? To rule out the lung metastasis. Lung metastasis. Okay, and then you have to go for follow up. Okay, follow up for which levels? Beta hCG levels. Sir, question was asked, till how long you will go for follow up of beta hCG levels? Remember, it is 6 months. It is how many months? It's 6 months. But if more than 40 years age, family complete, we can go for hysterectomy. Is that clear? To everyone? So if age of a patient is more than 40 and the family is complete, we can go for hysterectomy. Okay, now my dear students, we also use a chemotherapy regime, because the complication, what can be the complication? Complication can be gestational trophoblastic neoplasia. Okay, it will include 3 things: ICP, it will include invasive mole, Okay, it will include choriocarcinoma. Let me write it clearly. It will cause GTN. Write the full form: gestational trophoblastic neoplasia. Gestational trophoblastic neoplasia. Usually three things: ICP, I, that is invasive mole; C, that is choriocarcinoma; P, that is placental site trophoblastic tumor. For invasive mole and choriocarcinoma HCG levels, we follow up beta HCG levels. For placental site trophoblastic tumor HPL levels, we check. Okay, then sir, we use a regime called as IMACO regime. क्या है regime का नाम बच्चे? So we use a regime called as IMACO regime. Now what are the drugs in the IMACO regime? So E is, yes, E is etoposide. Chalo, E, etoposide. Okay, M is methotrexate. Okay, A is actinomycin. Then we have C, it's cyclophosphamide. And O is oncovin. O is oncovin. EMACO, that is IMACO regime. Okay, now depending on the low risk and high risk. Okay, for low risk, okay, my dear students, for low risk, okay, for low risk you will use, for low risk we will use a drug, only one. If low risk less than 7 score, okay, too many things, components to calculate this score. Just remember, if low, less than 7 is score. If low, you will only use methotrexate, a single agent along with the folinic acid. If high risk, more than 7, you will use multi-agent therapy. And the multi-agent therapy is what we discussed IMACO regime. Is that clear? The multi-agent therapy is what we discuss IMACO regime. Okay, methotrexate के साथ give folinic acid as well, because it will decrease the toxicity features. What is an antidote for methotrexate toxicity? That is folinic acid. क्या है antidote? Folinic acid. And you will use this methotrexate on the day, on day 1, 3, 5, 7. ठीक है, with 1 mg per kg. 1 mg per kg. Okay, plus folinic acid. So this is all about the IMACO regime. This is all about the high datiform mole, IMACO regime, and molar pregnancy. Clear? Yes, guys. Chale. Now tell me, what will be the management of this patient having a high datiform mole? Okay, so management is suction and evacuation. Clear? And I've already mentioned that you have to mark, if a examiner will ask that for how long the follow-up for HCG is needed. Follow-up for HCG is needed for 6 months. Follow-up for HCG is needed for 6 months. Follow-up for HCG needed is 6 months. Clear? Yes? Chalo. Good. Now let's discuss about the next chapter or next topic, vaginites. Now tell me, a 30-year-old woman, she present to your OPD with the complaints of foul smelling discharge for past 3 weeks. On examination, the discharge is thin, so creamy white, and has a fishy odor. All the classical features. of bacterial vaginosis are there on addition of 10% of KOH. That's fifth test. What is the most likely cause? So your diagnosis is bacterial vaginosis. It's the most common type of, vaginitis. So tell me, if a patient is having a bacterial vaginosis, what will be the treatment? Sorry, what will be the causative agent? Bacterial vaginosis. What is a what is a causative agent for bacterial vaginosis? Yes, it is Gardnerella. Very good. It is Gardnerella. It is C. Okay, guys, questions are easier ones, PYQ based. But what's more important? What's more important is a topic. Okay, what's more important is a topic. Okay, so make sure you are fully what prepared for all these topics. Okay, chale. Everything is clear so far? Yes. 1 hour more and then we will complete. Okay, we'll complete this remaining part, then we are done. ठीक है, चले. Okay, sir. Now let's discuss all these three: candidiasis and bacterial vaginosis, and then followed by that trichomoniasis. Now if we talk about the candidiasis first, guys, it's mostly caused by Candida albicans. It's mostly caused by Candida albicans. Okay, remember, it occurs in acidic pH. It occurs in acidic pH. Okay, then remember, in candidiasis the spores are responsible for infection. Spores are responsible for infection. Spores are responsible for infection. Okay, and for the invasion of this candidiasis, in the vaginal epithelium, mycelia is the responsible. So I will just write, sir, mycelia, so you'll understand, for invasion. Mycelia for invasion. Now we have a classical type of discharge that is seen in candidiasis. C for candidiasis, C for curdy discharge. Okay, or cottage cheese like. C for cottage, C for cheese, C for curdy. Cottage cheese like discharge that is seen in a patients with candidiasis. Okay, cottage, curdy or cheese like discharge which is seen with candidiasis. And if we talk about a treatment, if we talk about the ointment or the cream, okay, cream, we use clotrimazole. Okay, and sir, oral, we use fluconazole. Oral, we use fluconazole. Is that clear? So that is all about the candidiasis. Okay, mostly caused by Candida albicans, occurs in the acidic pH. Spores are responsible for infection. Okay, spores are responsible for the infection, followed by that mycelia, invasion of an candidiasis into the vaginal epithelium. The discharge is curdy discharge or cottage cheese like discharge. This is a question that they can ask. Along with that, remember, the fluconazole is a drug of choice, and also treat both male and female. Okay, that is about candidiasis. Okay, next one is trichomoniasis. If we talk about the causative agent of the trichomoniasis, it's caused by Trichomonas vaginalis. Sir, it's caused by Trichomonas vaginalis. It's caused by Trichomonas vaginalis. Remember, candidiasis acidic pH. Here the pH is alkaline. There is alkaline pH. Okay, alkaline pH. Okay, and now the in trichomoniasis it might show clue cells, but the diagnostic feature, if I talk about these clue cells, they are more with which type? Bacterial vaginosis. But in trichomoniasis it may show either whiff test positive or it may show clue cells as well. It may show whiff test positive or it may show clue cells as well. Okay, now if we talk about the discharge, guys, if we talk about the discharge, there is frothy or greenish discharge. So there is greenish discharge. Okay, followed by that, due to the severe irritation, due to the severe irritation, we have a strawberry vagina. Okay, due to the severe irritation, there is a strawberry vagina, which is also called as colpitis macularis, which is also called as colpitis macularis. Strawberry vagina, which is also called as colpitis macularis. Okay, what will be the drug of choice, bache? What will be the drug of choice? The drug of choice is going to be metronidazole. Drug of choice is going to be metronidazole. Again, it was question asked that in trichomoniasis both male and female are treated, so the partner is also treated. Partner is also treated. Okay, they can give the image based question of this Trichomonas vaginalis. Okay, it's a flagellate organism. Under the microscopy you can see there is a flagellate organism having flagella. This can be the image based question. Okay, there is also a recall question, image based question. Chalo, next one next one is the bacterial vaginosis. Now bacterial vaginosis, it's the most common type of vaginitis. Sir, it's most common type of vaginitis. Number first thing. Number second thing is, again the pH is alkaline. There is alkaline pH. The pH is alkaline, so it's an alkaline pH. Okay, followed by that, it can cause, bacterial vaginosis can cause abortion, it can cause preterm labor. Okay, it can cause pelvic inflammatory disease. Okay, that we have learned in the main session. Here, crisp and concise, right? The criteria for this is called as Amsel's criteria. What is the name of the criteria? So the name of the criteria is Amsel's criteria. So we have four things in Amsel's criteria. We have clue cells, we have creamy discharge, we have fishy odor, we have whiff test positive. And at least 3 should be present out of 4. 3 out of 4 for diagnosis. 3 out of 4 for the diagnosis. So Amsel's criteria, that is all about the bacterial vaginosis. Okay, again the drug of choice for bacterial vaginosis, metronidazole. Okay, one question was asked in the last NEET PG PYQ, that simple question, which the score is used for. Nugent score is used for, just they did not tell to calculate. Nugent score is used for, that is bacterial vaginosis. Nugent score for bacterial vaginosis. Is that clear? Nugent score for bacterial vaginosis. Okay, so that is all about the trichomoniasis. bacterial vaginosis and candidiasis. Trichomoniasis, bacterial vaginosis and candidiasis. Clear? And one question from this particular topic is confirmed. One question from this particular topic they will ask. Okay? All clear, guys? Write down in the comment section all the people who are watching. Any doubt so far? All clear? Any doubt so far? All clear? Yes. So let's move to the next question. Chalo. Next. A 30-year-old primary attends the antenatal clinic at a period of amenorrhea of 35 weeks. She has a single fetus in a breech presentation. Ultrasound scan confirms the presentation. No other abnormalities are detected. What is the next step in the management? What is a next step in the management? Now, my dear students, a patient is coming to you for an antenatal checkup. Okay, she's coming to the clinic. She is 35 weeks pregnant and now she has a fetus in a breech presentation. That is confirmed by the scan. There is no other abnormality detected. Make sure you remember all the key points that I've highlighted. No other abnormalities are detected. What is the next step for NVD? Now, let's discuss what exactly is a presentation. Okay. Now, presentation means pole of the fetus lying on lower segment. So, pole of fetus lying on lower segment. Pole of the fetus lying on lower segment. Okay. Now, if a head is in the lower segment, I call it as cephalic presentation. If a shoulder is in the lower segment, I call it as transverse or shoulder presentation. If a breech is in the lower segment, I call it as breech presentation. I call it as breech presentation. Okay. Now let's write each of them. So what does cephalic presentation mean? It means head is at lower segment. So what exactly shoulder presentation means? It means shoulder is at lower segment. It means shoulder is at lower segment. And what exactly the breech presentation means? It means breech is at lower segment. Okay, shoulder presentation को और क्या बोलते हैं? So it's also called as transverse presentation. इसको और क्या बोलते हैं? So it's also called as transverse presentation. Okay. Now, as I've already discussed in an amniotic fluid dynamics that whenever we have a transverse presentation, there are multiple scenarios. If a patient is in the labor, I go with a cesarean section. If a patient is not in the labor, I go with an external cephalic version. If a patient is having a transverse lie at 32 to 34 weeks, all I can do is wait and watch till 37, 36 weeks. At that time, I can rotate it externally. Is that clear? Now remember that what is the next step? Now remember that what is the next step? What's the next step in the management of normal vaginal delivery? Now, what is the next step in the management of normal vaginal delivery? Now, cephalic and breech presentation. If there is a vertical lie, now cephalic have different types. Now, what are the cephalic presentations? So, head was in the lower segment. Now, this head, due to the extension and the flexion of the head, this head can be this way on the face side or the other side, brow, vertex or face. Okay. Now, if cephalic and breech has a vertical lie, now, if cephalic presentation or breech presentation is having a vertical lie, I can deliver with a normal vaginal delivery. I will deliver with a normal vaginal delivery. Okay. Sir, if a shoulder presentation has a transverse lie, Now if a patient is having a shoulder presentation with a transverse lie, okay, so how to deliver? I have to deliver through cesarean section, but depending upon the scenarios, okay, depending upon the scenarios. Now what are these scenarios? Let's write. Okay, now what are these scenarios? Let's write. Okay, now sir, in a term pregnancy, uterus is relaxed, the woman not in labor. So if term pregnancy is there, a uterus is relaxed and woman is not in labor. When a woman is not in labor with a breech and shoulder presentation with transverse lie, what you have to do? If she's not in labor, so I will go with external cephalic version. So write two scenarios at 37 weeks. At 37 weeks, not in labor, okay, with transverse lie, you will go with external cephalic version, बच्चे. So write a short way, external cephalic version. Next, sir, at 37 weeks, okay, if in labor, if a patient is in labor, okay, at 37 weeks, if a patient is in the labor and with a transverse lie, you mark cesarean section. So two scenarios. So if at 37 weeks not in labor, external cephalic version. At 37 weeks in labor, then cesarean section. So around 30 to 32 weeks, am I going for external cephalic version? No. So write it down. If a patient around 30 to 32 weeks with a transverse lie, not in labor, what you will do? So I will not go for ECV, because why we are not doing? Because amniotic fluid keep increasing. And baby will change the position. This is the reason, that's why we are not going for external cephalic version. Okay, so remember three scenarios. If a vertical lie, नॉर्मल वेजाइनल डिलीवरी. अगर ट्रांसवर्स लाई है और लेबर में है पेशेंट सिजेरियन सेक्शन. अगर लेबर में नहीं है at 37 weeks external cephalic version. अगर 30 to 34 weeks है, don't do it, just wait till 36 or 37, then go for ECV, because if we do it prior, baby will change its position. Okay, now breech. Okay, now breech presentation. Breech is touching the lower segment. Now we have three types of breech. We have complete breech, okay, we have frank breech, and we have incomplete breech. We have complete breech, we have frank breech, and we have incomplete breech. If we talk about frank breech or we talk about complete breech, it can be delivered normal vaginal delivery. That's right, normal vaginal delivery. Okay, that's right, normal vaginal delivery. Okay, so frank breech and complete breech, normal vaginal delivery. Incomplete or the footling, we go for cesarean section. Most common type of breech is going to be frank breech. Okay, now the best type of breech which can be delivered through normal vaginal delivery, frank breech, which is also called as extended breech. Okay, now for extended legs, now when we have to deliver this breech presentation, for extended legs we have to use these maneuvers in order to do the delivery of a breech presentation. For legs we use a maneuver called as Pinard's maneuver. Okay, for extended arms, okay, for the arms, when you love someone, you hug them with your arms, so arms के लिए Lausset's maneuver. Lausset's maneuver. Okay, after coming head, there is jaw flexion and shoulder traction, which is known as Mauritius simile weight maneuver or Mauritius simile weight technique. Okay, and the forceps, outlet forceps that we use in order after delivery of the head is called as Piper's forceps. So that forceps is called as Piper's forceps. We have a technique other after coming the head. We have other techniques: Burn Marshall technique and retigence maneuver. Now, what exactly is the Burn Marshall technique? Once the body of the baby is delivered, this much part. Okay. After that, you need to let the baby hang for a while. Okay. See, let him hang until you can see the hair at the back of the neck. Now, baby is hanging, head is still intact. Okay. You deliver the legs with the Pinard's maneuver. Okay, you delivered the arms with the Lausset's maneuver. Now you need to deliver the head. Now for this head, I'm using a maneuver called as Burn Marshall maneuver. First of all, same image was given in a NEET PG exam. Which type of maneuver is that? Your answer is Burn Marshall maneuver. Okay, now once you see the hair on the neck, okay, let him hang for the while. After that, hold his feet and free his mouth and suck him out and swing his head clear. Okay, let him hang, hold the feet, and then free his mouth and swing the baby, so that head will be delivered. Okay, so swinging all these images, hang, then swing, hold the feet, this maneuver is called as Burn Marshall maneuver. The question asks, the outlet forceps that we use, this forceps that we use, it's called as Piper's forceps. They can ask this question, what is the forceps used? You will use Piper's forceps. Okay, next, this shoulder traction, jaw flexion, shoulder traction technique. This is the image based question that they can ask. This is a Mauritius weight technique. Okay, and this is a modified retigence maneuver. What we do, we put the moderate upward pressure which is applied on the fetal chin and with the posterior hand covered with a sterile towel. Okay, while the suboccipital region of the fetal head is held against the symphysis. So towel image, and you apply the pressure on the fetal chin. Okay, this maneuver is a modified retigence maneuver. This is a modified retigence maneuver. Clear? Okay, these all four maneuvers, this breech presentation and this particular side is very, very important. Now a lady at 35 weeks is coming. Okay, she's in breech presentation, not in labor. She just came for antenatal clinic. So ultrasound confirms there was no other abnormality. What is the next step for a normal vaginal delivery? बच्चे क्या करोगे आप? Sir, I will perform the external cephalic version at 36 weeks. I will perform the external cephalic version at 36 weeks. At 36 weeks. Clear? Okay? Chalo. Because at 36 weeks, the level of amniotic fluid will be decreased. Okay? Followed by that, let's discuss about PCOD, polycystic ovarian disease. Jaldi se. Now, sir, this is also known as, this polycystic ovarian disease, it's also known as Stein-Leventhal syndrome. Stein-Leventhal syndrome. Okay, now you already know that the main reason for this PCOD is what? Insulin resistance. The main reason, the pathophysiology is insulin resistance. Okay, and if they ask what is the most common endocrinological disorder in a reproductive age group, your answer is going to be PCOD. Your answer is going to be PCOD. Now, in order to diagnose this PCOD, we have a criteria called as Rotterdam criteria. What is the name of the criteria? It is called as Rotterdam criteria. In a Rotterdam criteria, we have three things present over there. Okay, first thing is there is hyperandrogenism. First thing, there is hyperandrogenism. Okay. Second thing is there is no ovulation, that is anovulation. That is anovulation. And third thing, that there are USG features of PCOD. There are USG features of PCOD. So what is Rotterdam criteria? Such three things in the Rotterdam criteria. Sir, hyperandrogenism, anovulation, and USG features of PCOD. These are the USG features, the classical appearance of pearl of string appearance. Okay, and what should be the criteria? among these three, two should be present over there. Okay, now you know in normal cycles the bleeding is due to the progesterone withdrawal. After the LH peak, LH surge हो जाता है, उसके बाद progesterone आके progesterone withdrawal हो जाता है 14 to 28 days. The secretory endometrium is there. But in case ovulation is not happening in the PCOD, the shedding of endometrium, it's not due to the progesterone, it is due to the ischemic withdrawal. So remember, ischemic withdrawal is responsible for the bleeding in PCOD. And ovary is larger. How much? It's around 2 to 6 mm large than a normal size, and the stroma is 10 to 12 mm thick, and stroma is 10 to 12 mm thicker. Okay, followed by that, patient is having increased androgens, due to which patient is having increased androgen called as hyperandrogenism, and due to increased level of androgen, patient is having hirsutism and acne. As already discussed, that due to the insulin, PCOD is due to the insulin resistance. That's why there is less glucose in the ovary. Okay, so there is less energy, these follicles do not grow. So what is the mainstay of the treatment? We need to give energy to glucose these follicles so that follicles will grow. Okay, now this insulin resistance will have a cutaneous marks on the neck called as acanthosis nigricans. So acanthosis nigricans, it's also seen in diabetes, obese, but यहाँ पे भी दिखता है किसमें? PCOD में, because insulin resistance is there. This is insulin resistance cutaneous mark called as acanthosis nigricans. Okay, this is acne due to hyperandrogenism and hirsutism. All these three features of PCOD. Okay, now the appearance on USG is called as ring of pearl appearance. So it's called as ring of pearl appearance. Okay, now we have association syndrome, HAIRAN, Hydran syndrome, where HA is hyperandrogenism. Okay, followed by that we have IR, insulin resistance. Okay, and AN as acanthosis nigricans. So hyperandrogenism, insulin resistance, and acanthosis nigricans. Okay, long-term PCOD, metabolic syndrome, 3 out of 5 should be present. In components of metabolic syndrome, okay, let's have a quick revision of these last slides. The triglyceride levels, okay, in case of a metabolic syndrome, the triglyceride levels should be how much, right? It should be more than 150 mg per deciliter. Okay, it should be more than 150 mg. It should be more than 150 mg per deciliter. The HDL should be less than 50 mg per deciliter. Okay, blood pressure should be more than 130 by 85, sorry. Okay, then the fasting blood glucose should be 110 to 126. Okay, and the abdominal waist circumference should be more than 35 centimeter. Okay, more than 35 centimeter. This is all about metabolic syndrome. Clear? This is all about metabolic syndrome. Now, sir, treatment. For the treatment, you know that ovulation is not there, so I will induce the ovulation. I will give ovulation induction drugs. But prior to that, an ovulation treatment, the first line management will be lifestyle modification. First will be lifestyle modification. Okay, followed by that I can give the insulin sensitizer, metformin. Insulin sensitizer, a drug, metformin. Okay, then I can give aromatase inhibitor, clomiphene, letrozole. letrozole, which is a aromatase inhibitor. I also use a one more drug for ovulation induction called as clomiphene citrate. Clomiphene citrate. These are all the ovulation induction drugs. Now, patient is having hirsutism due to the hyperandrogenism. Now, I can use anti-androgens as a treatment. I can use OCPs as a treatment. I can use the spironolactone. That's what we give, aldactone drug, spironolactone. Okay, we can also use cyproton acetate for acne. That is all about the treatment for acne. Okay, surgical treatment. Now the stroma is thick in this PCOD patient, so I will try to decrease the thickness of the stroma by ovarian drilling. So we go for laparoscopic ovarian drilling. We go for laparoscopic ovarian drilling, which will decrease thickness of stroma. Which will decrease thickness of stroma, so the better follicular growth will be there. Okay. Now next question, a 25-year-old woman undergoes the first trimester ultrasound which shows a twin pregnancy. So twin pregnancy. Now the twin pregnancy, the ultrasound shows that there is a separate placenta and separate amniotic sac. So separate placenta, separate sac, one twin, one baby. Next baby, separate placenta, separate amniotic sac. So can I say that it is a case of a dichorionic? It's a case of a dichorionic diamniotic pregnancy, twin pregnancy, DD. It is a case of dichorionic diamniotic. Okay, now let me know that what is the most likely timing of the embryonic division. Now you know the fate of the monozygotic twins. Now twins, okay, the main reasons, it can be multiparous woman. Okay, it can be elderly, it can be due to the treatment of IVF, it can be due to the ovulation induction drugs like clomiphene citrate, letrozole, all other things which will increase the chances of a twin pregnancy. Now when we have two types of twins, having monozygotic twins and dizygotic twins. Now the monozygotic twins have a different fate depending upon the day on which the cleavage will take place, right guys? Now if the cleavage is taking place between day 1 or day 3, I am having a type of a pregnancy called as DD. How do you remember DD? Dichorionic diamniotic. If the cleavage was 4 to 8, between 4 day and 8 day, the type of an twins I have is MODI, monochorionic diamniotic. If the cleavage is taking place between day 8 and 13, day 9 and 13, the type of the twins we have is monochorionic, monoamniotic. And if it is more than 13, we have the conjoined twins. So here I have a separate, here you can see the examiner asked, said there is a separate placenta and separate amniotic sac. So the type of the placenta, the type of the twin pregnancy is dichorionic diamniotic. And see here in dichorionic diamniotic, the cleavage takes place between day 0 and 3, between day 0 and 3. Is that clear? Is that clear? It is between day 0 and day 3. So if it's mentioned that monochorionic diamniotic, it will be between day 4 to 8. If between 9 to 13, your answer should be monochorionic, monoamniotic. And if the cleavage is more than 13 days, answer goes to conjoined twins. Okay, conjoined twins. Okay, now if we talk about the chorionicity scan of these twins, if we talk about this sign, this is called as lambda sign. This is called as lambda sign or the twin peak sign. So lambda sign or twin peak sign is a classical sign seen in dichorionic diamniotic type of twins. Okay, dichorionic diamniotic twins. Okay, and if I talk about T sign is a classical feature of monochorionic diamniotic. It is monochorionic diamniotic. So T sign is seen in monochorionic diamniotic, and twin peak sign dichorionic diamniotic. Dichorionic diamniotic. Clear to everyone? Clear to everyone? Okay. Followed by that, we have episiotomy. So what is episiotomy? Okay, episiotomy is a surgical planned incision. Surgical planned incision which is given on perineum, given on perineum for the widening of the birth canal. For the widening of the birth canal. Okay, so whenever there is a shoulder dystocia, macrosomic baby, or obstruction or breech presentation, we go for an episiotomy so that a baby will pass smoothly. We widen the birth canal with the incision. Okay, now see here, we'll do the incision mediolaterally. Okay, here, so that this will be what, the widening of the birth canal. Okay, now what are the structures resected? First of all, we'll cut the skin. Followed by skin, we cut the subcutaneous tissue. Okay, followed by that, followed by subcutaneous tissue, we go for superficial transverse perineal muscles. Superficial transverse perineal muscles, followed by that deep transverse perineal muscles. Then muscle fiber of bulbospongius and levator ani. Followed by that, we have transverse perineal branch of pudendal nerve. Transverse perineal branch of pudendal nerve. Okay, and last में we have posterior vaginal wall. Last में we have posterior vaginal wall. This is all about the structures which are resected in episiotomy. Structures resected in episiotomy. Now, what are the muscles which do not cut? We do not cut during episiotomy. First thing, remember ischio-coccygeus. Okay, then ischio-cavernosus. Then anal sphincter. And obturator internus. Then obturator internus. These are the muscles which do not cut during the episiotomy. And we usually perform, we have two types, usually midline and mediolateral, but we perform mediolateral episiotomy because there is less wound extension. Is that clear? And these classical seizures are called as episiotomy seizures. They can ask the image based question. These are episiotomy seizures. Episiotomy seizures. Okay. Now followed by that, a woman present to the OPD with the complaints of amenorrhea for the past 2 years. She has a history of postpartum hemorrhage and lactation failure. She complains of appearance of vitiligo-like white patch also. What is the probable diagnosis? What is the probable diagnosis? Now, my dear students, the probable diagnosis here is Sheehan syndrome, because after postpartum hemorrhage, she is having a lactation failure. Okay, so you all know that for lactation we need a prolactin, and prolactin is coming from pituitary. So once a patient is having this postpartum hemorrhage, there is a decreased blood supply to the pituitary as well. And when there is a prolonged ischemia, so when there is a blood loss going on in the postpartum hemorrhage, the oxygen is traveling through the blood only. Okay, there is decreased blood supply to the pituitary as well. Prolonged loss of blood supply will lead to the ischemia, and prolonged ischemia will lead to the necrosis. So eventually there is postpartum pituitary necrosis, or there is post pituitary necrosis. Okay, that's why the Sheehan syndrome is also called as postpartum hypopituitarism or postpartum infarction or postpartum pituitary infarction. Okay, now what happens in this Sheehan syndrome? All the hormones that are coming from the pituitary will be decreased. Now when there is no FSH, no LH, estrogen progesterone भी नहीं हो रहा, there is no proliferation or secretion of a endometrial tissue, and eventually what will happen? There will be no menses. Okay, prolactin is coming from there. There is no prolactin. That's why a female is complaining of a lactation failure. Okay, first symptom. There is no vasopressin. There is no vasopressin. That's why decreased vasopressin antidiuretic hormone. Patient will also having a features of diabetes insipidus, and TSH के साथ भी patient will have features of hypothyroidism. Patient is also having a features of hypothyroidism. So let's write Sheehan syndrome. So it's also called postpartum. So it's also called postpartum pituitary necrosis. It's also called postpartum pituitary necrosis. Okay, it occurs when the pituitary gland is damaged. It's damaged due to the significant blood loss. Due to the significant blood loss. Okay, it's also known as postpartum hypopituitarism. Postpartum hypopituitarism. Now what are the clinical features? I've already said that, sir, if we talk about earliest is patient will have a lactation failure. Patient will have lactation failure. Followed by that, patient also have other features like secondary amenorrhea. Patient is having diabetes insipidus. Patient is having hypogonadism as well. And patient is having thyroid related disorder as well. Okay, now what will be the treatment? So treatment will be all the hormones that are deficient will substitute those hormones. So right, substitute the hormones. Substitute the hormone. That is about Sheehan syndrome. That is about Sheehan syndrome. Is that clear? Is that clear? Yes. Chalo, next. A 24-year-old woman who is being treated for infertility with HMG. She complains of sudden abdominal pain, nausea, vomiting, and breathlessness. The finding of ultrasound is shown below. What is the most likely diagnosis? Now you know when we are going for IVF, okay? Now we give the stimulation therapy with HMG. Sometimes there is over hyperstimulation, and that over hyperstimulation will cause the features abdominal pain, vomiting, breathlessness, and the complication is called as ovarian hyperstimulation syndrome. So this is the classical image, OHSS, ovarian hyperstimulation syndrome. Okay, now this ovarian hyperstimulation syndrome, it's characterized by multiple ovarian follicular cysts which are accompanied by increased capillary permeability. It happens most often as a complication of ovulation induction therapy for infertility, IVF, that as I told you, and it occurs due to the stimulation of a vascular endothelial growth factor expression in granulosa lutein cells by HCG. Okay, so remember OHSS. In this we have in the center appearance, but in PCOD that is on the periphery. In PCOD वहाँ पे क्या होता है, difference क्या है, periphery में, ये central में present होता है. Now if question will be asked, drug of choice of an ovulation, normally you mark clomiphene citrate. Okay. Now due to the an ovulation due to the PCOD, you mark letrozole. Okay, an ovulation due to the pituitary ablation, you mark HMG. An ovulation due to the Kalman syndrome, go for pulsatile GnRH. And for ovarian control ovarian stimulation in IVF, mark HMG. Okay, a bit fast in the last lap. Okay, guys. Then last is gonna be the signs, the question that we ask. If there is a bluish discoloration of an anterior vaginal wall, we call this as Jacquemer or Chadwick sign, seeing along 8th week. If there is an increased pulsation through the lateral fornices, it's around 6 to 8 weeks, called as Osiander sign. The softening of the cervix, need PG recall, it's called as a Goodell sign. Okay, it's a cervical sign. If there is an asymmetrical uterine enlargement in lateral implantation, this is called as Psake sign. On bimanual examination, okay, the abdominal wall, abdominal and vaginal fingers, they oppose below the body of the uterus. This is called as Hagar sign. And the Palmer sign, the last one, the rhythmic and regular uterine contractions which are elicited on the bimanual examination. This is called as a Palmer's sign. Okay, these all signs are important. They can ask this Hagar's was asked with a picture, and this Goodell sign, softening of the cervix, was also asked. Is that clear? So that is all about the part 2 revision. Okay, guys. So God bless and good luck. Okay, revise. Okay, share the video with your friends as well. Okay, I will post the PDF in my channel as well as in the Meduhub channel, both part 1 and part 2. Okay, in the last couple of minutes we're a bit fast in 2-3 topics. Okay, but that's fine. So I hope revision was good enough. Okay, if any doubt regarding this session, any question, anything related to this, feel free to ask anytime. Okay, you're always welcome. Okay, you guys can ping me up in the Telegram any doubts, but doubt should be related to the studies. Okay, we'll have a PSM sessions in coming days, part 1 and part 2, then followed by that pediatrics. Okay, revise all the sessions. Last lap is important. Remember, trust yourself, trust your efforts, trust your studies, and let's get this exam done. Okay, so remember, we never lose, we either win or we learn. Okay, my best wish with you guys. I hope that all the topics that we covered in this session, that will be very, very important, and that will be very useful for your upcoming exams. Okay, so thank you for being interactive. Okay, so God bless you, all the best, you got this.